Good evening, ladies and gentlemen, community partners, healthcare leaders, faculty, students, esteemed guests from Niagara University, Japan. Welcome to all. Welcome to HealthTech Horizon Symposium 2024. It is with great excitement and privilege that I welcome you to the symposium. Today marks a significant milestone in our journey towards revolutionizing healthcare through technology. And I'm deeply honored to be here today, guiding you and facilitating you through insightful discussions and conversations. Together, we embark on a journey of exploration, collaboration, innovation that holds of improving and our healthcare profession and outcomes. So I want to talk about the visionary course that we have to kind of take from where we are today in 2024 to, I would say, 20 years, 30 years down the lane. This journey started from me being and I'm telling my grad students, an unsure student who really loved about brain and neuroscience, but didn't know, how to kind of get there. But slowly, with the help of my mentors, my teachers, and my people who really believed in me, I'm kind of seeing myself transforming into this faculty who really believes in empowering her students. It really helps me to kind of understand why I am here today and what I want to do in future. Like the transformation that you would think in terms of a butterfly. And I think that is what is needed for us to grow, evolve, and transform. I think transformation is the key, and that's what we learned in our early biology lessons from Charles Darwin. I think great innovations cannot happen alone. Great innovations need great leaders, visionary leaders, transformative leaders, and that's what we are seeing in the presence of our President Sandoval and his core team and leaders around the Fresno State University. I want to acknowledge Provost Fu. He really wanted to be here, but he couldn't be because of he has to be in another meeting. I really wanted to acknowledge our interim dean, Dr. Zographos, who is here. I really want to thank some of the people that I met for the first time at the university for this conference, and that is Dr. Bao Johari, because of which I could have this webinar. Because of this, I was having to kind of have making sure that the technology kind of goes smoothly, and I hope it does. I also want to acknowledge Mr. Mark's Tai, and he has a DXI hub for students. So there is a lot of digital and technological transformation already happening at Fresno State, and I feel so comforted that our leaders are already thinking about the future. I must congratulate the president about the strategic goals that he put out in 2023 to 2029. I thought that kind of really lays out the foundation for what we need to do in our next 5 years. I think that is really aligning well with our college goals at College of Health and Human Services. You saw the vendors that we had outside. I really want to kind of say thank you and kudos to them, and some of them from coming from far off to really help our students understand what technology means, how it feels, and what we can do about it. I think it is very important that when education meets with technology, you need to try things out. My journey with telehealth started in 2019, and that had really served me well during the pandemic when I had to kind of, with my colleagues, transition our on campus gait balance and mobility clinic into an online clinic. I think we use remote therapeutic monitoring. We made our patients work during the pandemic, and some of them were logging in 19 hours of physical therapy. And that was amazing. It was a 75-year-old female who was kind of doing this because she wanted to be independent and out and about because she lives alone. So it is important about touching lives and making sure that in many ways, I think I want you to understand that telehealth is not about delivering care remotely. It is also about enhancing accessibility, about empowering patients, and making sure that they are in charge of their own health. So, equally important for them to kind of exercise and do things and making sure that they are doing it and taking their health in their own hands. Currently, I'm treating this Parkinson's patient. He's a retired uh, boxing coach, and he was really perturbed when he's not able to even walk 34 steps. And I am using a virtual reality to making sure that this gentleman can be independent. Patients want exercise to motivate them, and we want them to adhere to these exercises. So we have to kind of meet them in the middle somewhere in making sure that these exercises are they are able to do it day in day out and they are not bored of it. Interestingly, with the remote therapeutic monitoring app, as you can see in the picture and in the figure, the initially on the walk score was 39 and then it became 70. I want you to pay attention to the number of steps. He started with just 20 steps that he could take, and he was all over 978 steps by 2 months. That was phenomenal for me. The next time I saw him, he was greeting me by coming to me and not me going there and helping him. These stories make you understand why you are in this profession and what you want to do with this profession. I want you to think about the future. I think it is really important to understand that the future of healthcare embedded in technology has opportunities. As in terms of the global healthcare analytics, it is right now at 43 billion in 2023, going to go to 53 billion by 2030. I want you to also address the barriers. The barriers are 43% of the task force right now is not tech savvy. And it's not just about technology, they are hesitant to try technology. So where can we meet them? What can we do? What Fresno State can do and what we can do for the valley and beyond. I think that takes a lot of courage. That takes a lot of determination. It takes a lot of people and it takes an attitude to change. My solution to that, in my humble opinion, is that Fresno State should start a center for digital innovation and technology. Fresno State should think about what it can do to deliver in terms of the curriculum revamps, in terms of doing courses, in terms of catering to not just the national but the international students. I think we can be the leaders in making sure that we are delivering to people who really want us. So here I am proposing that maybe in the next 5 years, with all the minds in this room and all the great minds in the valley, maybe we can do something and change what we are currently doing. I want to thank my physical therapy department, my organizing committee. They make me shine just like family. I feel that they are my extended family because they show grace when I do things which are not appropriate, and they help me and put me, on the top when I do something good. So I really acknowledge them and really say thank you for making me shine today. Now let's welcome our guest of honor. I want to talk about our president. President Sandoval is the dynamic and visionary president of California State University, Fresno, with a profound dedication to Central San Joaquin Valley's economic and cultural advancement. As a passionate advocate for higher education and proud product of region itself, he has done something really amazing for the valley. With roots deeply embedded in the community, his leadership has propelled Fresno State to national and international recognition. emphasizing inclusivity, innovation, and research excellence. Under his guidance, Fresno State has implemented transformative initiatives like Bulldog Bound, fostering a college going culture and enhancing access to education. President's leadership is characterized by his unwavering belief in the transformative power of education and his dedication to empowering students from diverse backgrounds to reach their potential, making Fresno State a beacon of opportunity and excellence in higher education. I really want to let you know that when I was planning the symposium, he was the first person I reached out, and not knowing whether, with his busy schedule, he can accommodate us. But he replied even before the administrative assistant could reply and saying, Nupur, I really hope I can make it, and let me look at my calendar. And that's the leader we are talking about. So please put your hands together for our President Sandoval.
Thank you very much. I should be giving you a gift. It's not the other way around. Thank you. Thank you very much. So it's a true honor to be here with all of you today. I take this opportunity to learn what's happening within your department and what the future also holds. That's really tremendous. In the life of a president, I don't usually get to learn, and I usually get to interact with people who are innovative and who are moving forward. So it's truly refreshing to me to be here. Thank you for the kind invitation. So good evening to everyone. And especially a special good evening to our healthcare professionals and our guests from Japan, from the Niigata University Health and Welfare in Japan, and all those as well joining us online. I want to thank Dr. Nupur Hajela for all she has done to make this event possible, and also the organizing committee, and for her kind invitation to speak to you today. I'm here as a president, but I'm also here as a citizen of this valley. I'm honored to stand before you today to address the crucial intersection of digital transformation and healthcare delivery at the HealthTech Horizon Symposium 2024. Hence, in today's rapidly evolving world, the integration of digital technologies into healthcare is not just a trend, but now it will become a necessity of the everyday. Digital transformation holds immense potential to revolutionize patient care, improve healthcare outcomes, and enhance overall healthcare delivery, and also train healthcare practitioners, as we saw outside with the two demonstrations that you have here. Through this comprehensive symposium, which is hosted by the College of Health and Human Services and the Department of Physical Therapy, we aim to equip our participants with the knowledge and skills necessary to navigate this dynamic landscape effectively. This comprehensive symposium is a clear case for the value that our universities provide our region. You foster greatly needed innovation and excellence in a field that has the potential of promoting a deeper sense of trust, availability, and confidence in our populations. How so? When someone is trained effectively, you as a patient notice that immediately. You notice it immediately. And that's the first step towards the patient saying, this healthcare practitioner will actually effectively be good to me, treat me. I have to trust my healthcare practitioner in order to say, I'm going to convey to you what is happening with me. That's the very first foundational step. Trust, it is. So, trust is fundamental because it allows our healthcare professionals to provide an effective prognosis. And then the follow up, of course, will be fundamental as well. In the world of today, we have smartphones and we have algorithms within these smartphones. How can we harness the power of these algorithms in order to provide better healthcare to our population? That's going to be one of the big challenges that we have. And of course, this is just the tip of the iceberg. Innovation distinguishes a university. Why? The more research we do, the more innovation we do, the more known we are, and the more we separate ourselves from the pack and then get ahead as a university overall. So this is an important symposium for me because it establishes this leadership within Fresno State in a very effective way. I hope that this symposium facilitates further collaborations within our community partners, healthcare systems, industry partners in the Central Valley, and beyond. I'm sure the symposium will serve as the pivotal force for advancing health equity for underrepresented patient populations. Through its visionary discussions and innovative solutions, it will empower healthcare professionals to dismantle barriers to care access and prioritize inclusivity. Lastly, I want to talk to our talented students who are here today. The greatest lesson that Fresno State gives you is to think outside the box. What does that mean? Once you graduate, you have to be creative, which means you have to undo the lessons that your professors have given you. How so? You have to become your own professionals in your own right. And that's going to be the greatest challenge when you reach that level of excellence and you say, now I am me. Now I am me. I have parents? Yes, I do. But I have reached the level of excellence that distinguishes my own philosophy of what I, as a healthcare professional, am going to do with my own patients. That takes a lot of courage. After you do that, you need to reinvent yourself over and over and over and over for a lifetime of opportunity. Because if you don't, you will become stale and you will become stable and you will not be able to keep up with the healthcare professionals. So remember, think outside the box, break those glass ceilings, and go dogs. Thank you. I will take this.
Thank you, President. Yes.
flat file.
Thank you. Okay. Thank you, President. Now I want to call upon our interim dean, Kara Zografos, who is an accomplished leader and educator serving as the dean of College of Health and Human Services. With a wealth of experience in public health, Dr. Zografos brings a dynamic approach to advancing college missions of preparing students to address critical healthcare needs and special issues. Her expertise lies in health policy, healthcare management, and community engagement. Under her leadership, the College of Health and Human Services continues to thrive as a hub of excellence in education, research, community service, and making a significant difference in lives of individuals, communities, and faculties like us. Thank you. Oh,
Well, good afternoon, everyone. So it's really a pleasure to be here with all of you today. We have community partners, we have healthcare leaders, faculty, staff, and students from Fresno State, international faculty and students from Nagata University in Japan, and community members joining us today. Welcome to all, and what a blessing to have so many together in one room and online. As we've seen throughout the years, healthcare needs have not only risen, but shifted to adapt to new modalities and technologies that have enabled health and human services professionals to continue serving our diverse communities. I'm so excited to hear from our speakers and panelists today about how these new technologies can improve our healthcare delivery system. Here in the College of Health and Human Services, our students, our faculty, and our staff are privileged by the ability to engage in innovative research. And we have state-of-the-art labs, we have simulation mannequins to explore clinical care and virtual reality. These hands-on experiences have far-reaching benefits, and I expect they will in the years to come. I am so proud of our faculty here at Fresno State for realizing the importance of digital and technology transformation. This event is just one example of that, and I know in the years to come, we will have many more. I want to thank our faculty for participating today for their time and energy on this important topic. A special, heartfelt thanks to Dr. Nupur Hajela and the faculty in the Department of Physical Therapy. As I was sitting in the audience listening to you, Dr. Hajela, I had this incredible sense of proudness. Proud of you, proud of the faculty, proud of our students, and really, we are fortunate to be here at Fresno State. I'd also like to recognize our healthcare partners that are joining us this evening, including those from UCSF Fresno, Omada Health, Covered California, One Step, Mount St. Mary's University, Neuro Rehab VR, California Telehealth Resource Center, and of course, our colleagues from Fresno State. That's quite a group. Thank you all for joining this conversation. I look forward to hearing more from each of our speakers and panelists this afternoon. The collaboration here today is invaluable and really critical to the success of our valley and the health in our valley. So thank you. And now I'd like to welcome Dr. Hajela back to the podium to introduce our keynote speaker. Thank you.
And now the moment we are waiting for. I want to introduce our keynote speaker today, who drove all the way from San Francisco to be here and speaking to us on such a rainy day. Dr. Todd Norwood, Senior Director of Clinical Services at Omada Health, is a pioneering figure at the forefront of telehealth innovation and clinical leadership. Dr. Norwood, Senior Director at Omada, is a pioneering figure at the forefront of telehealth innovation. With a remarkable background as a founding member of Physera, he played a pivotal role in scaling and leading the nation's first telehealth physical therapy network, marked by groundbreaking contributions to patents in computer vision and machine learning. Following Omada's acquisition of Physera, he spearheaded the company through a period of unprecedented growth, particularly driven by the challenges posed by the COVID-19 pandemic. His visionary leadership extends beyond operational oversight as he champions excellence at the nexus of clinical best practices and clinical advancements, notably steering Omada to first digital musculoskeletal provider to obtain URAC's telehealth accreditation. Dr. Norwood's expertise as a telehealth thoughtful leader is widely recognized with numerous publications in esteemed journals and invitations to present at prestigious conferences and associations. His commitment to leveraging data and technology to enhance patient outcomes is matched only by his dedication to community engagement and advocacy. As our keynote speaker today, he's going to talk about unparalleled insights into transformative potential of what telehealth can do with the intersection of healthcare, technology, and patient-centered care. Please put your hands together for Dr. Todd Norwood.
Everybody hear me? All right. Thank you for being here this evening. It wasn't that bad of a drive, just Californians don't know how to drive in the rain. But I made it safely, so it's all good. So a couple things we can go over today. Really, for me, it's innovation and how innovation is going to drive healthcare as we move forward into the future. How we're going to use technology and how we're going to use data to get there. But before I get too far, I'm going to give you a little bit of an introduction about me. So as Nupur said, I'm from Northern California. I live about halfway between San Francisco and San Jose. That's where I was raised, and I've lived almost my entire life. I live there with my wife, Samantha, who's a pediatric physical therapist, and our son, Henry. We also have our hairless cat, Milton Bradley. So if you don't remember anything after you leave today, you'll probably remember I have a hairless cat named Milton Bradley. Um, yeah, I love technology. I've loved it from a very early age. And so I now have the pleasure to, and honor, honestly, to use that passion to help patients and drive patient care forward for the better. And when I'm not doing that, I love cycling. I love everything about it. So a good day for me is going on a bike ride, coming back, making an espresso, and then harvesting something to eat for lunch or dinner out of my vegetable garden. Okay, so I just told you that I love cycling. That's hidden a little bit, but I'm going to tell you why I shouldn't love cycling and why I shouldn't love data. So a couple pictures. This is a much younger me. Maybe I'm regretting this a little. I didn't realize they'd be this big on the screen. But let me tell you the story. Okay, so on the left here is about 25 years ago. It's the first time I did a bike race. I had no idea what I was getting myself into. Neither my parents either, to be honest. But it was 18 miles. And I finished it. I crashed 4 times, but I finished. Okay. I finished an hour behind the winner. So you have to know anything about cycling to know that's not competitive in the slightest. And somehow I said to myself after that, I can beat these guys. It's pretty bold assertion for a guy who like beat up and finished an hour behind. And so I start on this journey. And to be honest, it's a journey I'm still on today to learn about the sport, learn how to be better at it. And I learned about heart rate monitors as something you do to monitor your training. So I saved some money and I bought one of these things and I started training with it. I was riding with it on, looking at the data later. And I was fascinated by it. It was so interesting. I'd see how it would change over time. So when science fair time comes around, I decided I want to do a project looking at how heart rate changes with training. And so I get a bunch of jump ropes and I recruit a bunch of my friends and I do this project. And it gets me to the state science fair where I'm in that second picture down in Los Angeles, waiting to present my posters to the judges. And I present it. I can remember this like it's yesterday. Judge asked me, do you have any statistics? I say the only thing that comes to mind in my 14-year-old head, which is, do you mean like the type on the back of a baseball card? Not what he was looking for. And again, after that experience, I could have like tucked my tail, but I said to myself, I need to learn about statistics so this doesn't ever trip me up again. I just can't let this beat me again. And so here's what I learned. You take those two experiences, you have some data, you have some time, and you learn that if you want to look like a bike racer, you get the clothes that fit right. No, but really it's this. It's what Steve Jobs said. So you can't really connect the dots looking forward. I had no idea at that time that those experiences would be so pivotal to how I live my life moving forward, but absolutely they were. So you have to look back. You have to trust the process that all the little things that happen in your life, they're driving you to a place. And if you take advantage of them, you'll get to a place that you want to be and that you're happy with. So let's talk about innovation. Now you know who I am. Let's talk about why I feel it's so imperative that we innovate within healthcare. So, innovate verb. Key part here for me is that it's not necessarily about creating new in and of itself. It's not to recreate the wheel, it's to take what's in the world and make it better. But thinking about that, you don't have to build something brand new from scratch. You can, but you can just make a lot of the things in the world better. The other thing I'll tell you is that healthcare providers are innovators. Healthcare has a long history of innovation. Looking all the way back, 1815, stethoscope. Think about how much that changed patient care compared to what we did before, which was the doctor putting their ear up to the patient's chest and listening to the heart and lungs. Stethoscope's a lot better. But then x-rays, penicillin, AEDs, these are all game changing advances in healthcare that were driven by healthcare providers responding to a need they saw. You've got EMRs, which love them or hate them, they are here, they're going to stay. And they do have the potential to make healthcare a heck of a lot better. And then recently, COVID vaccine. How fast did that happen? I mean, it's incredible. It was built on other innovations, but it came around in an incredibly fast manner. So we are innovators. Don't let anyone tell you that innovation is the domain of Silicon Valley, that it's the Apples and Googles of the world that innovate. No, no. Right here in this room, and the people that came before us, the shoulders who we stand on, we are all innovators, and we can innovate and we can change the world. And the reason why this is so important is this: it's leverage. Innovation is our lever. There are 7 billion people and counting on this planet, and they will all need healthcare at some point in their lifetime, at many points in their lifetime, right? We all do. But there's not enough healthcare providers. There's not enough hours in the day to take care of all those people. So we need innovation. That's the lever. That's how, as healthcare providers in the healthcare profession, that we can extend our reach beyond our clinic walls, beyond our community, and serve all the people that truly are in need of our services. If we don't innovate, we'll never get there. There will always be unmet need. But if we innovate and we're thoughtful about it, we can really expand the reach of what any one of us can do in the hours that we have. And technology is a big piece of that, in my opinion. And of course, I'm biased, right? I live in Silicon Valley. I work for a tech company. What else am I going to say, right? We got to use technology. But truly, it's a technology. It's a really a catalyst for us. So, Steve Jobs, second time he's showing up here. I might be a little bit of a fan of Steve Jobs. But think back to this. You probably don't remember this the way I do, because when in 2007 I was in college and I was doing tech support in college. And when the iPhone came along, that totally changed how our networks operated because now there were way more devices on the network, and that made my life very difficult. So I wasn't really a fan of Steve Jobs in that moment. But nonetheless, think about what he says here. And I love, if you haven't watched this presentation, I actually like watched this before I came because it gets me psyched up to do a presentation. It's so good. But he said, okay, we're three products here: an iPad, an iPod, the touch iPod. Well, heck, those things are gone now, right? We don't talk about iPods anymore. A mobile phone. The last piece is key. The last piece: breakthrough internet communications device. That is really the game changer because this is in my pocket, but I don't even know. I probably take phone calls on it 5% of the time, less maybe. No, it's not a phone. It's an internet communication device. That's the key piece. And yeah, 2007, there are people who are going to start university in the fall whose whole lifetime the iPhone existed, which seems pretty crazy to me. All right, so mobile devices are our catalyst. This is some of what I do and the work I do at Amada Health. So telehealth encounters, fantastic, right? Telehealth encounters at the scale that we have them today are really enabled by mobile devices because there's billions of mobile devices out there that can access the internet at a sufficient speed to handle a video encounter. We can go beyond that, right? These little computers in our pockets can leverage AI and can do measurement and feedback. So we can use computer vision to accurately measure a range of motion. We can use augmented reality to provide real-time feedback for a patient. And then education and communication, right? Going back to that idea, breakthrough internet communications device. We can communicate in ways that we couldn't before. So when I started in the clinic, I handed people a piece of paper. I hope that they kept it and got it and didn't lose it. Now it's on their phone. They're not going to lose their phone. I'm not worried about that. It's right there for them at their fingertips. Now, just because we can doesn't mean we should. I think that's an important piece of it. I can do telehealth encounters, but should I? And the answer to the question is yes, if it's appropriate, if it's the appropriate patient and you're the appropriate practitioner. So you have the experience, you have the discipline to do the yellow flag screening, the red flag screening. You have seen enough patients to know when things don't line up. So I think as students here, that would be one of the things I would impress upon you is I wouldn't run out and get a telehealth only job right away. I would work in a clinic for a couple of years. I would develop your own database of patient cases so you understand when things are awry, when your spidey sense should tingle a little bit and know when it's not quite right for telehealth. I think that's crucial. I spent 6 years, I did residency, got two specializations, and then I timidly saw my first telehealth patient because I wasn't sure about it. You've got to have a little bit of fear. You've got to have a little bit of something that makes you uneasy at the pit of your stomach, and you have to know when you need to refer somebody. So, getting that experience is invaluable to enable all the things that we can do with telehealth and to do them effectively. But what's really cool, and like this makes me happy, this is our research from a couple of years ago, is you take technology, you enable care, and you can get outcomes. You can get good outcomes. And all the research, not just ours, is showing that telehealth outcomes are on par with in person outcomes. This is fantastic. And it opens doors for all sorts of people who may not have selected physical therapy as a way to treat their condition. Going further, one of the things that we found in our study is that over 50% of the people were able to see their physical therapist within 24 hours. This is unheard of. I don't know what it is here in this community. For my wife up in Santa Clara, 6 to 8 weeks for her to see a new patient. So you go 6 to 8 weeks or 24 hours. I think it's pretty clear that you've now got some people who are now in our corner wanting to have physical therapy because it's easier to access. And then this one. So you want to talk about innovation? This is a poster I did a couple of years ago. I did have the statistics this time. This was, 20 years on. I figured out what the statistics were and knew what to talk about when I did my poster presentation. This is a feature that we built. We called an asynchronous assessment. The concept is this: the patient records themselves performing their exercise, the therapist reviews it asynchronously and provides feedback. How did that come to be? So, very early on, before RTM and RPM existed, I was working at Fazera, which was then acquired by Amada, and one of the software engineers comes to me and says, "So, Todd, why do you have patients do exercises in the clinic?" I said, "Well, it's to teach them and it's to give them feedback. And let's be honest, it's to bill for something because I can get reimbursed for that." I said, "Okay, well, what if you had them take a video of themselves, okay, and you then watched it later and gave them feedback?" I said, "Uh huh. Could you bill for that?" "Well, no, Cam, that would be fraud because the billing codes are set up that it means synchronous in person." Say, okay, well, but in principle, are you not doing the same thing? Are you not watching them do the exercise and giving them feedback to correct their form and make it better? And you're using your skill as a physical therapist to do that. I said, no, I totally agree with you. That's what's happening, but the billing codes don't allow for that today. And so we had this long conversation and we agreed that in principle, it could be the same thing and that maybe we couldn't bill for it today, but that it was the right thing to build because it allows for patients and therapists to optimize their time and their interaction. Now, my patient can do their home exercise program after dinner, and I can watch it in the morning and give them feedback before they do it the next day. So it just makes it easier for everybody. And if I have a no show, for example, for a telehealth encounter, I can review a few videos and send them off to my patients. It makes the system more efficient. So even though we knew at the time in 2018, when we started building this, that we couldn't get reimbursed, we did it because we felt it was the right thing to do. And look, now there's RTM codes, right? And RPM codes. And so now it sort of fits in. But that's innovation, right? Taking the technology that's there, new iPhones could record video. I mean, we knew you could send it to a PT. So we had all the components. But the other piece I want to impart on you with the innovation is as a therapist, I wouldn't have thought that because the codes didn't allow it. As a technologist, he wasn't burdened by that. So a lot of times when you think about innovation, you need somebody with the outsider view. So us going to somebody in technology because we don't know what's possible, somebody from a technology background or another background coming to us and offering ideas because they're not constrained by the same things that we are in our day to day. Okay, Now we talk about data. Like my other love behind cycling is data. So let's talk about data. We gotta, you know, love our California sports team, even though they're struggling a little bit now. But the Oakland A's, right? Moneyball was really the Oakland A's organization looking at data in a different way and turning sports, baseball first, but sports on their head. And baseball is really beautiful in that way because everything's been recorded for over 100 years in the same fashion. Every single pitch, every hit, every ball in play, it's all recorded in the same fashion. There's scorebooks from years and years and years and years, and you can get all the data and you can analyze it and you can look at it. And when you do that, you find patterns, you find trends, and you can change business as usual, right? And so if you watch the movie, you know about Billy Bean, but really his failure was he looked like a baseball player in terms he was strong, athletic guy, but he didn't succeed. And up until that time, and until he really started this revolution, scouts looked for baseball players that looked like baseball players, but they didn't evaluate any deeper. The data let us evaluate at this different level. And it's not just changed baseball, right? It's changed any sport you want to watch today. Whether you want to look at basketball and shooting 3-pointers or football and going for it on fourth down more often, data has completely changed sports and it's completely changed other industries as well. I mean, look at what happens on Amazon, right? They know what you want to buy before you do. Also, technology makes more data available. So Amazon, Netflix, Facebook, Instagram, where you're being served ads, that's about data being available to try to figure out what you might want before you know you want it. But in this world, let's think about PT. Think about the clinical world. I see a patient on Monday, I give them some instruction, they come back on Thursday. I don't know what happened in between until I ask them. But now, in this remote world, with an app that tracks their progress, I can know what happens in between. I can have them record their exercises for me. I can have them send me videos. They can send me chat messages. They can do patient reported outcome measures along the way. And I can get all this data and update my plan in smaller increments. The way I think about it is like if I'd driven here with a paper map today and like decided I needed to turn off because there was traffic. I had to stop, side of the road, get the map out, figure out where I was going, and then figure it out. But then like GPS, right? This is like GPS. I'm driving down the street. It's like, hey, look, if you go keep on this route, it's gonna be 5 minutes slower. But if you take a right up here, you're gonna get there 5 minutes faster. And like, okay, I'll take that right. Oh, nope, not that right. The other one, right? And then it starts recalculating. And if you live in San Francisco, it's even better because if you miss your turn, there's like a one-way street going the wrong way, and you gotta like go 3 blocks around. So this is like the GPS, right? You're all used to driving with GPS. This is like GPS for your PT. It's allowing you to make those small corrections much faster than you would if you have to wait for the patient to come back into the clinic. The other thing is data tells us how. Data can tell us how we get from point A to point B. In this case, and I'm going to tell you students all something that I think you probably already know. If the patient does their exercises, they get better. That's what the data told us. Now, it told us a lot more than that, though, because then you want to know, well, okay, how do I get the patient to do their exercises, right? Like, that's great. I figured that already. How do I get them to do their exercises? In our data, we found three things. One, follow-up visits. And the more you have to a point, we found 5 in our data, you could increase the probability that they're going to do their exercise program during the week. The other thing, so simple, send them a message. Send them a couple messages a week. And that engagement with the patient increases the probability they're going to complete their home exercise program in a given week. And the other piece is the access. Now, this is a observational study, so correlation, not causation, but getting people in sooner helps with that. Probably because they're motivated, right? They're motivated and they get started right in that moment of need. And they don't have to wait. They don't have to wait and let it linger. The data can tell us how we get there. And we got to talk about AI, right? It wouldn't be a complete conversation about technology in 2024 if we didn't talk about artificial intelligence a little bit. And I left it as a question mark. Does artificial intelligence transform healthcare? Probably in time. It's not going to do it today, but in time, I think it will. And the hot topic here is generative AI. That's what ChatGPT, Bard is the Google version, Copilot is what Microsoft has in some of their products. It's fantastic. It's really, if you haven't played with it, you should. It's fantastic. It's very interesting, but it's not going to replace clinicians anytime soon. It'll help clinicians at some point. It'll need to be refined at some point. But there's all this other fun stuff in AI, like computer vision, to identifying, like you can imagine doing a gait analysis with computer vision or measuring range of motion, providing feedback like I showed earlier. That's an option. You've got machine learning, right? Just like dumping in a ton of data and allowing the machine to learn and pick out the patterns and then apply that learning to new data that it hasn't been given access to give you insights. And then natural language processing. And some of these things generative AI is built on top of, but being able to parse language. And so there's really powerful things of you could imagine you had all the records of the conversations digitally between patients and therapists. You could find the words and the sentences and the phrases that were most likely to drive a specific patient action that you wanted. And then you could educate people on how to best communicate with patients. And you could be very specific about, well, what's this case? Am I concerned about ACLs or am I concerned about stroke rehab? You could dig into that and figure that out using some of the power of artificial intelligence. And I think that those opportunities are where we go and where we get, again, the leverage to really make impactful change. So is IA going to be the lifesaver? Not overnight. It's going to take some time. So like don't think you're just going to show up to the clinic when you start PT as a professional and AI is going to do half your job. Like that's not going to happen. But with AI, I think it's important to understand that data comes first. AI has huge potential, but AI needs one, a lot of data. And if it's going to be really useful, it needs to have high quality data. And one of the things that I think is important when we talk about healthcare is we have to have data that represents the population, right? So it's not just one age bracket, it's not just one ethnicity or race. It has to be really broad, and we have to have the right data. So I can't look at AI that's been trained on a bunch of college age men and apply that to a 47-year-old female. It's not going to work. It's not going to give me the right answer. So we have to have quality data. And really, there is a certain responsibility we have as practitioners to collect quality data, right? Because if somebody comes up here and lies on the table and we all do a manual muscle test, are we all going to get the same score? Probably not. That's a data quality problem. So then if you extrapolate, like, great, you all were trained at Fresno State. So there's a higher probability that you're at least consistent, but then extrapolate across the country. Are we all going to get the same score? Absolutely not. So now we have a data quality problem, right? So making sure that we have quality data, we all have standards. We all agree that a 4+ is a 4+. We all agree that 170 degrees of shoulder range of motion is 170 degrees. And we're pretty darn accurate on that. That's important for training these models. But also in seeking quality data, we have this responsibility. So I'll sneak in Spider-Man again here, right? With great power comes great responsibility. We have to protect not only the integrity of the data, but also the security and privacy because it's patient data, right? And patients are entrusting us with their oftentimes sensitive data. So in all this rush to build great AI systems, we can't forget the patients, making sure that it's de-identified, making sure that only the people who really need to have access to patients' specific and sensitive health information have that access, right? So the clinicians, but the data scientists, they're great. I work with data scientists almost every day. I love them, but they need de-identified patient data to work with to do their job. They don't need PHI. So making those distinctions and understanding, and in part, as we're thinking about innovation, we have to be mindful of that. And the other piece is, so there's an investment in quality. That's what I've been talking about. But there's also an investment we all have to make. We all have to be data literate. We have to understand the data. We have to understand what it means and how to work with it. And that's not necessarily something that we've all been trained in at baseline, but it's something that we'll all need to be trained in to really leverage AI. So just to wrap up here, I there's three things for me. So one, it's we have to innovate. We don't have a choice but to innovate if we want to have maximum reach in the healthcare profession. Technology is going to be part of that without question. And the technology is powered by data. That's just what it comes down to at the end of the day. So I'll leave you with this. This is a quote that I appreciate. We got to bring data. That's what it's going to come down to. So thank you. Oh, just gonna take a picture. I have long arms, so it works really well. Okay.
Let's go back to a slide.
There. We'll do my favorite one, which is there we go. All right. All right. Perfect. Thank you. Thank you.
Thank you, Todd. It was really wonderful. I loved it, and I love your enthusiasm for technology. So now I would request all the panelists to please come and be seated, and then I will introduce you. Well, this is so wonderful. I'm loving this. I'm loving everything I'm learning today. And I'm loving that we have to take data into account in terms of understanding what we can do and what we cannot do with our patients. So thank you, Todd, for those words. So now I want to introduce our panelists. So our next hour is a panel discussion. And the topic actually for the panel discussion, I'll tell you in a bit, but let me introduce you our esteemed speakers. Todd Norwood, I have already introduced Todd, and we had an exciting presentation that he has delivered. The next panelist is Dr. Seema Pulis Patil. She's a board certified internal medicine doctor and lifestyle medicine physician and a clinical assistant professor at UCSF Fresno. She teaches internal medicine residents and medical students. She has an MBA in healthcare management and is passionate about clinical informatics and medical economics. Dr. Pulis Patil works in telemedicine mainly during the COVID-19 pandemic, and most of the telemedicine she was delivering. She created curriculums for the medical trainees on telemedicine and continues to work on it to optimize healthcare delivery and patient safety. She worked on implementing e-consults in a federally qualified clinic in the Central Valley to reduce long wait times for patients to see specialists. Currently, she is working at the VA where telehealth innovation is transforming healthcare to increase access and connecting veterans with their healthcare teams. Our next panelist is my fellow colleague who I'm extremely proud of, and that is Dr. Hana Ko. Dr. Ko is an assistant professor in the Department of Physical Therapy at Fresno State. She's a board-certified pediatrics clinical specialist. Dr. Ko research interests are motor learning and control using non-invasive brain stimulation. However, as a board-certified pediatric clinical specialist, she provides extensive clinical experience and provide physical therapy and research services in the Central Valley. She initiated a community project promoting physical therapy services to help children in rural areas, especially in using telehealth. Through this project, Dr. Ko has identified great needs for PT services in remote areas in Central Valley. Our next panelist is Ms. Sylvia Trujillo. She's a distinguished leader and advocate driving equitable access to quality healthcare through digital innovation as the executive director of California Telehealth Resource Center. With a wealth of expertise in federal and California healthcare policies, Ms. Sylvia has expanded CTRC's partnerships with a keen focus on equity and sustainability. Her extensive background includes advising telehealth policies at both state and national levels, and also serving in pivotal roles in organizations such as OCHIN and American Medical Association. Her commitment to advancing healthcare technology and accessibility underscore her dedication to improving health outcomes for all communities. Before we get started, give a big round of applause to our panelists. So the topic for our panel discussion is challenges and opportunities in implementing cutting-edge digital and technology-related solutions in healthcare delivery. So panelists, I'm going to start a theme, and then probably each of you can take a take on it. So our first theme, can you guys hear me? Okay. So the first theme is on equity and accessibility. And the question that I want to propose to the panel is, as we embrace advanced digital solutions in healthcare, how can we ensure equitable access to these technologies across diverse populations? What steps can be taken to address potential disparities and making cutting-edge healthcare solutions accessible to them, irrespective of socioeconomic factors? Todd, do you want to start?
So I think there's a couple things here. One, I love, at least the data I've seen from Pew, and Cynthia, you can tell me whether it's accurate or not, is that so many people have mobile devices. So many people have cell phones. That's essentially the way a lot of people stay connected to the internet. And so that gives us a great opportunity. Now, broadband access is the limiting factor, as I understand it. So yes, people may have mobile devices, but one, when you think about socioeconomic status, paying that monthly bill can be a challenge for some people. So they may not have consistent access over time. And then broadband access can be challenging over time. And we were having a conversation before we came in that the library, these public spaces potentially as access points can be a solution for telehealth only. But when you start to think about other technologies, these technologies usually start in big academic centers, right? So if you live like I do near Stanford, they have really fancy high Tesla MRI machines and things of that nature, or surgical robots. And if we believe that those things are going to change outcomes, improve outcomes, then you have issues of getting access. And there are companies, I think Walmart's a great example, it's talked about a lot, where they actually will pay for their employees to go to a center of excellence if they have a condition that requires and will have better outcomes from that center of excellence, and it's known. And the reason they do that is for them, because financially it's better off for them to have that person seen at a center of excellence. So I think there's opportunities to think smart, like Walmart has done. Now they have massive scale, but now that's 1 million people. There's 300 million in the US. So at the state level, things like that. But really, I think, how do you bridge this gap between individuals that have a cell phone and a mobile device, and then making sure that they have the ability to connect via telehealth to service providers?
So I absolutely echo what Todd was saying. I'll just tell you an example that actually happened at the beginning of COVID pandemic. So, I mean, I don't know if y'all are aware, basically as internist, I had never done a televisit until 2020. So during my residency, we never had any telephone visits, never had any televisits, but this was an emergency, right? Basically, everything just fell apart and we started doing televisits. And this is, I worked in 2 clinics before. One was actually a private clinic, the other was a federally qualified clinic. And then in private clinic, it was an issue. Patient had insurance, patient had broadband services, patient had devices, either computers, laptops, or iPhones. So it was an easier access for that population. To come to a federally qualified clinic now, we have patients who are low on health literacy, number one, low on digital literacy, number two, no iPhones or no access to broadband, where we have to have these patients do face-to-face visits on the telephone or whatever devices. So we wanted to implement telehealth, and actually none of the providers, I was the director of the clinic at that time, and none of the providers agreed to do that, just because they were like, it takes me 20 minutes to do an in-person visit, but if I'm going to do the televisit with all the broadband issues, with all the device issues, probably it'll take 2 hours. And one of my best friends over there did agree to actually give it a trial. She said, okay, I have about 10 patients in the clinic this morning. Let me actually try and go ahead and try to do a televisit. And believe it or not, it took 2 hours to do one patient. Just because of the connectivity issues, the broadband, the patient is not understanding what we are trying to say, and then the language barrier too, right? So we live in Central Valley, where we have about 70% of Hispanic patients speaking Spanish coming to a federally qualified clinic. So for me, it's the same thing that Todd just said. It's about, how do we bridge this gap? How do we actually get access to these patients? And then library may be an option, but again, it's confidential. So again, are there any rooms that actually a library can provide that we can actually do these visits? And I know there is computer labs in the library, but it's a public space, right? But can we have booths? Can we have headphones where we can actually kind of build this connection, build this gap?
Well, since you mentioned about the federal funded agencies, so I can only speak for pediatric physical therapy areas, and I do work federal funded families through regional centers. So these are not coming from the private insurances. These are, again, federal funded. So usually those families are lower income, lower socioeconomic status. So when the pandemic started, because I never seen patients on Zoom, can we say it? Virtual visits. We never seen the patients virtually, but after pandemic started, for pediatrics especially, all the services has to transition 100% to the virtual delivery. So it was a quick transition, and we weren't really trained to evaluate and treat the patients virtually. So it was definitely some transition time for me to figure it out, how to identify their muscle tone by just looking at them without having any hands-on practices. But eventually I kind of figured it out, how to communicate with the parents and how to assess and how to treat the children. I mainly work with the infants and toddlers, so it's early intervention, which is age between 0 to 2. So it can be a little more challenging to see them through telerehabilitation. But then during the pandemic, I did the survey, like regional survey here, to see how many children that need PT services. So the survey was sent it out to the service coordinator in the regional center, and we found out that about 240 children are not receiving PT services. There are many reasons why we can offer services through, regional center. One can be the geographical barriers. They live far away, and early interventions mainly focusing on the home visits, but therapists, they don't willing to drive an hour to see them for 45 minutes to a 60-minute service and come back for another hour, right? So that was the one barriers. The other barriers were also the shortage of clinicians here in the Central Valley, especially pediatric PT. We are really in short. So we just don't have enough clinicians to see them. So it got me, it really made me think about what can I do for the community. And I try to kind of promote the telehealth because that was the only option during the pandemic. Second, I had to have a long meetings with the regional center because they didn't really buy the effectiveness of telehealth for the infants and toddlers. So there was like a long process of making sure that we are providing high quality services through telehealth. But through that survey, the interesting part that we figured it out was because it's so easy for us to get internet access. Everyone has a smartphone. We have Wi-Fi everywhere on campus or at home. About 14% of families, they do not have device or they don't have reliable internet access. So even if a telehealth was an option, we cannot provide them the services because they don't have the equipment, right? They don't have the services. And also to get the reliable Wi-Fi in the remote areas, it costs more money than, we're getting here in the city of Fresno. So that was another obstacles for sure. So in terms of access, we really have to think about not only providing telehealth, but also those devices and internet access. How can we provide them? Because that's something people living in big city may not think about, but if you live in rural areas, that is a big issue.
Sylvia?
So that seems grim, right? I think what you're really articulating is a model that's rooted in brick and mortar. So just really quickly, my name is Zoe Trujillo, and I spent about 14 years in Washington, D.C. with the American Medical Association as their senior Washington counsel. My portfolio included highly disruptive areas of medicine like genomics, digital health, and AI. I do have some thoughts about some AI, so I hope we come back to it because I do think it's more present than maybe it was characterized. What I'll say about health disparities and how we can use digital innovation to really bridge the gap is demonstrated by another organization where I'm the senior director of policy, and that is OCHIN. It's a national health IT organization, the largest in the nation of federally qualified health centers, Ryan White centers, local public health agencies, and now critical access hospitals. It represents the most underserved, our members represent the most underserved patient population in the country without any other network that comes even close our health system. And incredibly, what happened during the pandemic is that literally in under a month, every single member within this network, including the largest set of networks of federally qualified health centers in California, were online and ready to go with telehealth. And what was the difference? The onus was not placed on perceived deficiencies of a patient or their family, whether they had literacy or whether they had connectivity. The onus was placed on creating systems, a systems approach where there was infrastructure and support, technical assistance that was provided to a whole collaborative, where by the end of the process, an analysis was done retrospectively of the adoption of digital health modalities. And what was found in the state of California is that individuals who were housing insecure, individuals who were transportation insecure, we're more likely to use telehealth and audio only in particular. So the rate limiting factor is not your connectivity from broadband, because audio only remains a very important tool, as well as texting. Sometimes low tech is one of the better options that we have available. And so the reality is that when digital modalities are intentionally deployed with a perspective of building systems, engineering systems, so people are able to make the right decisions. Clinicians have the tools, so the onus is not on them to spend 2 hours, that they have the technical support and the infrastructure needed to meet patients where they're at. We know digital health works well. Now, is there a tremendous danger in deploying digital health in a way that will exacerbate long-standing health disparities? The answer is, you heard it here, yes. When there is not a proper infrastructure put in place to meet families and to support healthcare providers, we will not get there. And a classic example is, now that all the COVID-19 public health emergency flexibilities are being retracted, meaning flexibilities around who gets paid, regulatory restrictions, licensing restrictions, what we are starting to see is that disparities are starting to emerge in the adoption of these modalities. What does that mean? If you're a federally qualified health center, until January 1 of this year, you were not allowed to use remote patient monitoring services, because our remote physiological services or remote therapeutic monitoring services, because you weren't paid. Now, it's awesome if you can say, I'm not going to get paid, we're going to do it because it's the right thing to do. It's not sustainable, and it's not sustainable in the least resource communities. It's sustainable if you're an academic center and you have large margins of compensation. So in order for us to get to sustainability, we have to pay. And so just on that note for Omada, I worked on Omada's efforts when I was at the AMA in order to try to get coverage through the Medicare program, which eventually it did. But they were able to go through the long winter of non-payment, but many, many others, like Pear Therapeutic, which has one of the more innovative remote therapeutic services to address substance use disorder, never made it through their winter. And we have not seen really valuable adoption because they could not find a financial model of sustainability. So I know that's a long-winded answer, but I think there's lots of opportunities for how we can overcome structural inequity, and we can't put it on the backs of the families and the communities that are the least invested in resource. It's really on us and everyone in this room. Not only do you have to become skilled in your profession from a clinical perspective, but you are going to be leaders. You're going to be running centers, you're going to be running practices, you are going to be at flagship academic centers, and you need to have a systems approach.
Well said.
I just want to add on that. I agree. Actually, the audio calls did really go well. We ended up doing only audio calls, which actually did bring up our face-to-face within a week higher, just because we were doing audio only. So we ended up adopting only audio calls. And of course, you cannot do a lot of visual exam or any exam with the audio calls. And we had about 25 to 30% coming face-to-face after the audio call. So it was a success, but not in a way that we would have wanted it as a video call. But I absolutely agree with you. Thank you.
But I think that's an important point, though, because as a clinician, as a student, as you're learning, to do an audio call, you're taking away so much information. So you have to be very confident. You really have to have a deep experience, a database, if you will, of patient cases that you've seen in the past to be able to make the right decision of, is this somebody that I treat based on this audio call because I'm very confident in the diagnosis, or is this somebody that I need to have come down to the clinic and see me to make the next decision, or do I need to refer this person? And so it's really something that you have to develop the expertise in your practice to be able to effectively conduct an audio call and serve these patients.
I want to be really clear about, I'm not advocating audio only for the delivery of all services. I also want to be equally clear. My points are around, we build systems, and those systems have to have a series of step downs to account for the infrastructure we have. I will also note that I provide support for the California Telehealth Network, which is different than the California Telehealth Resource Center. And this is designed to help get FCC subsidies for broadband connectivity for providers all throughout the state of California who qualify. That typically that qualification is based on rurality, but the consortium that we support includes those nonprofit organizations, including FQHCs in urban areas. And that broadband connectivity is about to improve exponentially with federal dollars in the billions that will be drawn down by the state of California in other states to improve what we call mid-mile, but also will have an improvement for what's called last mile connectivity.
As Todd said, that actually led to my innovation of curriculum for the students to how to do an audio visit, how to do a televisit, how do you triage a call, how do you actually decide if the patient needs to come in now, if the patient needs to come in 48 hours. So that was an innovation. I just wanted to.
No, I think this is great. I think that makes us believe that, when we are thinking about these policies, I think we need people with diverse mindset in the rooms. I think because diversity makes sure that we are thinking from the lens, we are looking at the problem from different lenses. And that's what we kind of saw here. We have a clinician, we have an advocate, we have physical therapist, and then they are trying to kind of see how we can look at this problem and how we can make things efficient. I think the thing that kind of comes at the top is about not putting all the responsibilities at either the clinician or the patient, but actually building systems. So I think it is very important that when we are thinking of infrastructure, we are thinking about funding. I hope the policymakers are kind of thinking about this, how these entities can be funded. Okay, so that makes me kind of go to our next theme, which kind of gels well with what we had in discussion here, is talking about navigating the regulatory landscape. How can healthcare organizations effectively navigate the regulatory challenges associated with implementing cutting edge technology solutions or digital solutions, ensuring both compliance and innovation in the rapidly evolving healthcare landscape? Maybe someone else can start this time. Seema, you want to start?
Sure. So how do we navigate, right? So it's about education. Just let me tell you, education never ends, right? So education of the clinicians, education of the compliance officer of the organizations, and the education from the payers, or what do we call the responsible payers? Let me just put it that way. So basically, as I was telling you, I did not have any experience with telehealth when we started, right? And then the compliance officer sends us a little template and says, this is what needs to go in the template to make sure that we get built. So then we are like, okay, what needs to be there? Then we are transforming into building that into a template in the EMR. I'm actually an EMR champion too at my organization. So there we go. So I have all the hats, and then I end up building a template that actually fits in. So it's about education, education, education. That's what I think. And then, of course, the advocacy at the higher level needs to make sure that happens.
Anyone else?
So I'm going to ask a question of you all in here before I answer that question. How many of you are training to be clinicians, and how many of you are from another school and another discipline? So those that are training for PT or a clinical practice, can you raise your hand? Now, do we have anyone from any other school or discipline in the room? Okay. So this is, I think I have two messages. The first is, as someone who worked on behalf of clinicians for 13 years and advocating, the most powerful advocate in the room was not their legal counsel, which is what I served as, and as their policy advisor. It was the clinician. When we met with members of Congress, when we went to the state legislature, having a clinician with us to share their lived experience and share the experience of their patient population was the most compelling and powerful advocate in the room, hands down, every time, without question. And so really, if you want to address regulatory impediments to access to care or regulatory burdens like prior authorization, which is ubiquitous, and whether it's in-person care or virtual care, is the bane of most clinicians' experiences. You becoming cognizant of how you can participate in organized professional organizations, and it doesn't have to be organized medicine or an allied health professional. It could be in an organization that focuses on X, whatever your particular interest is, whether it's around reproductive health, gender equity, underserved communities. You can find an organization that's doing that work now, and you can participate and become knowledgeable of how you can drive that impact. The same is true at the state level, and you're even more powerful in the state legislative process. So to the extent that you are learning about these issues, that is quite powerful. I would say the other really important concept around addressing regulatory issues, and it's becoming more complex, both at the federal and state level, we are seeing a proliferation of regulatory obligations with regard to digital health and health IT. There are massive regulations that just came down around certified health IT that I will not pain you with, but at the same time, we have the state of California as a result of the Dobbs decision that is imposing some new requirements around segmenting data and information that will impact digital innovation and data capture. It means less data is available as we start to employ new AI models that, for example, for machine learning. So what can you do besides become an advocate and become knowledgeable and connect with an organization? You need to find allies in other disciplines, like in the business school and in the engineering school and over at the law school, that you need to create a cadre of like interested individuals, a center of excellence that pulls together these disciplines, and that becomes an even more powerful and compelling group of individuals that can more effectively identify solutions to what are ostensibly regulatory and potentially legal issues. But at the end of the day, they really are clinical or operational engineering questions.
Love what you said. I love the idea of collaborating across professions. And you know my regulatory officer, so you probably know the conversations that I've had with her. But that's so key from my side of it, because there's the regulatory side of wanting to change the regulation, and there's also the innovative side of wanting to drive new innovation and change something for the better for your patients, or to improve your business or improve care. And that also starts with those conversations. A lot of conversations I've had from an innovative standpoint is like, I've had an idea, I just go pitch it to our legal counsel, our regulatory officer, and just say, hey, just tell me what the landscape is around these things. Like, this is my idea. Just tell me where we're at. Go talk to the software engineers, the data scientists, or the other professionals who I would need their assistance from to get this crazy idea to actually come to fruition, because I ain't going to do it by myself, right? I don't have all those skills. I'm the clinician, but I can see it from the patient side. Oh, for my patient, this might make their experience better, improve their outcomes, or whatever it might be. But I can't do that by myself. So really understanding, and then the next level, really the superpower, I think, of getting these things done is understanding the language that those professionals speak and becoming fluent in it. Because when I go to legal and have a conversation, there's certain things I need to say and I need to present. There's certain things they're looking for in the conversation. And like, yes, patient's part of it, but like, well, what are you doing with the data? How does the data work? And sometimes I understand that. Sometimes I need to call my friend in data science and say, hey, I'm going to go have a conversation with legal and compliance about this thing we've been talking about. I need you to come so you can explain where the data is going, how we're capturing it, how the technical aspects of that work. And you don't have to become a data scientist. You don't have to become a lawyer or a compliance officer to do those things, but you need to be able to speak their language to a level of basic fluency because it makes those conversations go so much faster. I can tell you, my first conversation with the software engineers were painful because I didn't know their language. I didn't know how I had to convey my ideas in a language that worked for them. But once I learned, now I can go, you know, we don't work in the office anymore. It's not like over the water cooler, but like we can have a quick combo on Zoom and knock something out that 5 years ago would have taken an hour.
I was just going to say, the health organizations have come a long way. When you look at the IT committees or when you look at the compliance committees about 10 years ago or 15 years ago, I don't think there was any clinician on their committees. But now there is a clinician on each of these committees, and actually that does help in educating the clinician, but also taking their viewpoint and trying to build a system to make this work.
I thought there's nothing that I can really mention in this section because I'm into academia, so it's kind of different field. But I love what Todd just said because I was in a, when I was doing my PhD, I worked with engineers. A lot of engineers. I was the only clinician in the lab, so I completely understand the language difference. It took 3 years for me to understand their language, but the engineers are saying. But what I learned from that process is that if you want to be innovative or create something completely new, you have to work with other disciplines. The interdisciplinary collaboration really brings the new ideas. So that's what I, like if there's a one takeaway from my PhD program, that's what I learned from my PI. So in terms of regulatory challenges, again, there's not much I can really say other than the data. If I want the telehealth stays with early intervention, it is here now, but I'm not sure if they're gonna pull it away. But what I was thinking about it, I mean, families or children who lives in big city doesn't really matter. But the children who lives in the rural areas or remote areas, if they pull the telehealth away, there's nothing. So I'm like really, my fingers are crossed. Please just stay here forever so they can get some services. But to do that, I realized that we have to provide the data. Telehealth is effective. Is this as effective as in person? So that's something that we try to do, like as an academia, being in academia, do the research for that project. But I really think that we have to sometimes, from the clinician standpoint or the researcher standpoint, we have to show the data that yes, it is effective. Please keep supporting us for the families. Yeah.
I want to emphasize the importance of the evidence base and demonstrating the value proposition. I will say, though, that is not necessarily the rate limiting factor of whether or not telehealth will be continued to be covered by Medi-Cal and Medicare, and even commercial payers for that matter. And I would in fact encourage you all to consider your role. I can't call you to action for advocacy because I'm a nonprofit organization funded by the federal government as a California Telehealth Resource Center. I will say it's right now Congress is considering whether or not to extend telehealth flexibilities for Medicare. And that has to be decided by the end of this year because there are statutory prohibitions on the use of telehealth outside of a rural area, a designated clinician office or a hospital, restrictions on types of clinicians, including restrictions on OT and PT. And these restrictions are statutory, and you're like, why in the world would they restrict in statute the use of telehealth in this way? It's because the law that authorized the coverage of telehealth was passed over 2 decades ago, I believe. And it was built on the concept that a flagship hospital would provide services to a rural hospital or a rural clinic. And it was actually quite innovative at the time. Unfortunately, it's now codified in federal law for Medicare. And there is no question about the evidence base for appropriate coverage. The issue is whether or not it is going to score as cost neutral or cost savings. And so it's a financial question. And so what's really important is not just to show the clinical value, but it's important to demonstrate the value proposition that treating someone's condition earlier on in their disease progression is more cost effective than waiting for their health status to worsen and potentially become more acute or chronic and overall cost the healthcare system. But the evidence base is very important, especially as we have new modalities.
You can't advocate for you to be involved. I will. And I'll tell you the things that she's telling you, I learned by being an APTA member. I learned by going to APTA in Washington in the past year and just understanding how it all works. I know we probably all got that jingle when we were in school about how the legislative process works, but actually understanding that and understanding all the moving pieces. And you don't have to go to Washington. You can go to Sacramento if you're in California. They have CPTA organizes legislative days. Go up there, just soak it in and understand it first, and then you're going to be so much more powerful and so much more effective.
No, these are great pointers. I think not just them, I'm learning. I'm the House of Delegate for CPTA. That makes me think that I should go to Sacramento and advocate for this because I deeply feel that, like I said, remote care is still care, you know. So some of the themes that I emerge and I think the takeaways from this team panelist is I think what I'm learning is education is key. It's important to collaborate, but collaborate with people also who are outside of your, I would say, comfort area, which you have never, interacted with, whether it's software engineers, data scientists, just go grab coffee and talk about the things that you're passionate about, the care you're passionate about. Uh, Other thing that came in the conversation is I think like Todd said is understanding the language that the professional is speaking, and I think that way you will be kind of more, I would say, productive and efficient in making those conversations go beyond the conversations. And data for advocacy, I think that is I would say a take home for our students. We talk about telehealth, we talk about not just telehealth, we talk about the evidence based care. And now you understand why that is so important that we talk about evidence based care. Finally, I think it kind of boils down to finances and financial. And I think some of the really important points are laid is that yes, it's evidence based care, but you have to also talk about the value of care. You have to talk about why you, as PTs in the room, why prevention is so important than just treating. So those are, I think, some of the great points that came out of this conversation. That leads me to our third and final round of discussion of this panel, and that is around, the like let's get into the kind of weeds in understanding user adoption and training. So that is about user adoption is crucial for success of any technological implementation. How do you think healthcare providers can ensure smooth adoption of cutting edge digital or any technological solutions among both healthcare professionals and patients? Additionally, what roles does ongoing training play in optimizing the utilization of such technologies? Who would like to take this question first?
I can't help myself. So I'm with the California Telehealth Resource Center. So for us, it's very clear that for clinicians, adoption really comes down to about 5 questions, and for your practice. The first is the evidence base. Does it work? Is there literature to support this? The second, is it safe? Safety is regulated at the federal level if you're using a device, but it's also regulated as part of your clinical practice. So it's going to be your standards of care, and that's driven by evidence. A big one that we talked about, I think we touched on it, but it actually is arguably one of the largest rate limiting adoption barriers, and that is, do you get paid? And Omada found out the hard way, as did many, that if you don't have a CPT code, that can be really difficult. And if you have statutory impediments to coverage, if you're an OT or PT for Medicare under telehealth, that's a big problem. And so payment is a third big question. The other is, will I get sued? What does my liability look like when I'm using this modality versus an in-person, and is it well articulated, and are the guardrails clear for me? And also you have a different type of potential liability, and that's around, are you using a secure communication, and are you HIPAA compliant? And cybersecurity is a big component. Those are all compliance components. And then the last is really two parts. It's, will it work in my practice? Meaning, do I have the infrastructure? Do I have broadband? Do I have staff who are professionally trained and have the skill set? And we touched on the last one, which is my patient population. Have I really met them and met the technology needs that they have in the right place? I will say one thing about AI, because I want to make sure to get it in there. We already have machine learning AI systems that the FDA has approved and Medicare is covering. A good example is diabetic retinopathy screening, and it's being deployed in lieu of a human. And the innovators have accepted medical liability for it. So I just would urge you all, and we have a 8-part series. We're doing an introduction to healthcare AI with some of the national experts in this space. You do need to be learning about the different applications of healthcare AI, how it's regulated, and really what your responsibilities are as a clinician to understand the different modalities, the data that's being used, how these are trained, how they're validated, and how they're monitored over time in clinical practice. Because even if you're using a rule-based algorithm, you have responsibilities, but your liability is lower. But if you start using more advanced algorithmic systems, including those that use machine learning, it turns out the Office of Civil Rights will likely be issuing a rule later this year that says if you're using an algorithm that discriminates against patients, the developer and deployer may not be on the hook, meaning your institution. You as a clinician may be on the hook for discriminating against your patient. So it's really critical for you to understand your role, and we have lots of resources to help you do that at caltrc.org.
Anyone else?
So when it comes to adoption, there's actually a bell curve to go back to basics, right? So there is early adopters and the late adopters. So I'm hoping that actually the newer generation, we are going to change that curve a little bit, but at least until my generation, when EMR started a few years ago, it was a great task because younger generation was adopting it easier than the older generation, and the older generation only adopted it when it became a necessity and a compulsion and regulation. So of course, with all the new innovation and with the new regulations and new digital health, AI, there's a lot of things that will change with the demographics as well, I'm hoping. And then talking about AI, actually radiology is the first specialty in medicine that actually has adopted AI a while ago. And they're trying to make it again official and legal and everything. But radiology is the first place where they're going to actually use AI in depth.
So a couple things here, but I gotta tell you a story to get to the point, and it'll be short. So the whole reason I got started in this journey in telehealth was actually a patient of mine. And he came into the clinic and I was working with him, and he'd asked me, well, how would you use technology in your day-to-day? How would you use technology to make your life better? And me, I'm like, who are you? You want to know about what I do? And you want to talk about technology? Like, you're the best patient ever. You can stay all day. Let's talk. Anyhow, so he was one of the co-founders of Fazera, is what it turned out to be. And he had left Facebook with a friend. So here's the point. Make your technology like something they already know how to use. In that case, Facebook, Instagram, TikTok, whatever the app is. FaceTime, right? FaceTime for video calls. My mother-in-law talks to my son on FaceTime 4 or 5 days a week. So we know that population can use technology, right? It's not that they can't, they do, they already do. But if you can make your technology like something that they already use, and that goes for both the clinician and the patient, the end user. If your technology is very easy to use, it's built just like something they're already familiar with, it borrows cues, and then innovates and improves on things, makes their user experience even better in some way, makes it faster for them to do something, easier for them to do something. Perhaps we're going to leverage AI to write our notes in the future. That'd be great. We'd all be happy to get rid of that as long as we proofread and make sure it's right. Because if we go to court, we need to be able to attest that that was actually what happened during that visit. So it's those things. And so I think there's great AI use cases. And to be fair, like I'm a fan of AI and I'm a fan of using data, if for nothing else, because we're all full of biases, right? And our biases, AI's biases can get us in trouble, but our biases can get us in trouble, right? So there's plenty of, what if I come to the clinic and I didn't sleep well last night and I missed something? That's where having an assistant that's AI powered or data powered can really be powerful to like just give you that little nudge, alert you like, hey, did you ask that question today? Like, oh yeah, I forgot. Maybe I should ask that. Yeah. Oh, gee, that's interesting information. That changes what I'm going to do now. So it's not that it's a dance, right? And if you think about dancing, it's not always one leader, right? It's an interaction. It's one person leads, the other person leads, and ultimately you get something that's beautiful. And I think that's where we're going to end up with technology as we adopt it, as we use it, is this dance where we trade off, and the technology does some things better than we do, and we do some things better than technology. Because I think at the end of the day, as a patient, I don't want to take my prescription. I don't want to have my care plan delivered directly from a computer. I want to have a human that tells me and explains it to me and helps guide me through it.
I think as a clinician, again, like training is the key. Because I mean, Dr. Hazela and we try to, embed the telehealth into our curriculum here in Fresno State. Again, like when I had to see patients virtually, I didn't have any training, but when you work with infants and families, it's different setting because you are communicating with the parents and families, not to a child. So you are indirectly delivering the service through the family. So it definitely requires different skill set than what we learn from school. So I think again, it depending on what setting you're working on, what populations you're working on, but especially for pediatrics, it definitely requires different set of skills to work with the family because that's actually the key clients that you are dealing with. And how to educate the HEP, home exercise programs, because that telehealth 45 minutes, 60 minutes once a week wouldn't really change the child's gross motor unless family does their HEP every day. So it becomes more of the coaching model for pediatrics. And again, like to do that, we have to train to do it. But I don't think, I guess because of pandemic really triggered something in pediatrics areas, and I think this is a good time, I think, to, in terms of education, maybe we have to start educating students how to deliver services through telehealth and different populations. Your language might be different. How you are teaching HEP will be different, right? So that's something that we have to think about to be, like adopter of telehealth.
Yeah, I think, like you said, I think it is important that when you think about training, you think about curriculum, you think about standardization, you think about how you're going to make sure that, like we talk about test retest reliability, we talk about, validity, and I think that all comes from data. So I think it is very important. I personally feel as educators, I think the onus is on us to make sure that you as students are, in many ways are certified to be the telehealth providers. I know through, being a member of Academy of Leadership and Innovation, I took a telehealth certification course. So being a telehealth certified person, let me understand what are the ethics around it. What are the legal aspects around it? What does interportability means? Where can I practice, and what are the things that I can practice, and who I can practice on? So I think very important that first it is training for us, and then it is training for you. And I think what I kind of really learned from this segment is um, making the technology not as in many ways we versus them, or it is more about, I love the analogy, Todd, that you gave. It's a dance, and in dance, as you said, it's about give and take and making sure how you can make it something beautiful. So I think that is one takeaway for me. I also want to emphasize, I think, what you all said about the evidence. I think the data would be the key, and for us to understand that, we have to make sure that we are looking at the right places, and we are talking to the right people, and those right people could be around us. It's just about, when you think about adopting, I always try to think about, my neuroscience brains also thinks about neuroplasticity. The analogy that I would like to give, that when neuroplasticity is happening, things are messy, things are not perfect, but that they let you get something. So I think maybe because of the evolving nature of the digital healthcare space, we are not there yet. But that also means that I, being an optimist, I always want to think, the glass is half full. We have served so many patients, we have changed so many lives, we were able to get people out of pandemic and make sure that you were delivering care where they really needed it. So I think something was done right. I think it is about taking that data and talking to the policymakers, talking to the Congress, and I think that's where the advocacy came. So I think I want to end on that note, and thank you so much, panelists. I think it was a very engaging discussion. Okay, so we are right on time for our next segment. I would ask you to stay here for this one, just for the next one. And I want to introduce our next speaker, and then we will have a felicitation ceremony. Okay, so for our next speaker is Dr. Hubert Sikoti, and he's an esteemed associate professor in the Department of Computer Science within the College of Science and Mathematics at Fresno State. And he has a background in computer science from University of Lorraine, France. Dr. Hubert brings a wealth of international experience to his role. His expertise spans pattern recognition, virtual reality, brain-computer interface, cultivated through years of research and teaching across renowned institutions in France and Germany. As the IEEE senior member, Dr. Hubert is dedicated to advancing the field of computer science and contributing to innovative solutions that shape the future of technology. Dr. Hubert.
Thank you, Chair. Where do I click to get the slides? Oh. Thank you for staying.
Yeah.
And I have like 10 minutes. All right. So I'm going to talk to you about challenges brain-computer interface in brain-computer interfaces. So I will tell you what is a brain-computer interface and the challenges that we have, that people have, like to even for lots of applications. So how we go from the lab to clinical application, commercial application. I mean, that's a big issue. So you can do lots of experiments in the lab, works, you have some prototype, and after, well, you want to transition, you want to make it useful for people who need it. So that's a big issue. And if you just keep your application keep your systems in the lab, then they're not going to be used by people with disabilities or people. I mean, there are all kind of people who need what you do in your research. So going from the research to application of the lab outside of the lab. So that's a big challenge. So brain-computer interfaces. So you have two categories: invasive, non-invasive. I do non-invasive. So here, so I mean, my lab is in science too. Yeah, my lab is in science too. I use EEG, so you have different possibilities. I mean, if it's invasive, so you can put array of electrodes under the scalp. I mean, on the brain. Can use intracortical emitter electrodes. So there are different possibilities. And of course, well, it requires surgery, so I don't do that. Non-invasive, so you can use there are different possibilities. So you can use EEG, so that's the main one. FNIRS, so that's also possible, and MEG, so that's what I used before when I worked in the UK, when I was in the UK. That's very expensive. I mean, the MEG system, so that's a big piece of equipment, very expensive to run. You have to cool down the sensors. I mean, lots of issues for this type of sensors. But for EEG, so that's quite practical. So to move, I mean, to you can just wear a cap, put the sensors on the cap. So there are different types of systems. So the problem is that we have low spatial resolution, so high temporal resolution. It's portable for the functional near-infrared spectroscopy, so that's portable as well. But for the MEG, I mean, currently it's not portable. So there are solutions nowadays that are somehow transportable, but that's not portable. I mean, that's a big thing. Now for EEG, so what is currently used for the creation of brain-computer interfaces? So we use event-rated potentials, so ERPs. So you have different categories. So you have some based on attention. So P300, for instance, so P for positive. So you have an event, and after the event, you're going to have a brain response coming after that event. So depending on the category, depending on what you see. So for instance, yeah, P300. So if you have audible paradigm, you have different images, things coming out randomly. Then if you have a particular stimulus, let's say that is meaningful for you, then you see it, oh, there is a surprise effect. Then you're going to have this P300 coming, so 300, so with a latency of around 300 milliseconds, you have this wave, so you have different possibilities. I mean, you have different ERP components, P1, P200, and 170, so for the faces, so negative, you see a face, oh, you have this particular event coming. You have the visual evoke potential, so VEP, so you have different flashes coming, and based on how they're going to come, so if it's possible to have a code, like you have different sequences, so you can encode sequence for one action, another sequence for another action, and if your brain is going to respond, I mean, you can catch these responses. So P300, parietal, typically, visual evoke potentials, more occipital, that's where you're going to catch them. I mean, on the surface of the scalp. And by decoding these sequences, so you can get different commands, and you can use these commands, like say to move a robot, to move a cursor, you can do whatever you want. So once you decode these brain responses. Steady state visual evoke potentials, SSVP. So for main principle is you have different flashing lights, flashing stimuli, and you can encode different commands corresponding to the different frequencies. So you have light frequency flickering at 10 Hz, another one flickering at 12 Hz. Look in the occipital area, you're going to find something flickering at 10 Hz, flickering something at 12, and you can tell where the person was looking at. So, I mean, what stimuli the person was looking at. So you can encode different commands and then create brain-computer interfaces. You have also EEG changes, so looking at the frequencies. So in the mu band, so for motor imagery, so for event-rated synchronization, desynchronization. So that's where you want to look at when you think of, let's say you don't move your hand, you think about moving your left hand, moving your right hand, feet, tongue. Then you can here have 4 classes, and then consider a cursor, and you can say, okay, I'll move left, then I'll go left, I'll move right. Cursor is going to move right. I think about moving my feet. The cursor is going to go down. I think about moving my tongue. The cursor is going to go up. So you can encode something, a cursor to move on the screen. And for that one, so that's going to be, yeah, mu band, beta band. And so, yeah, 10, 12 hairs, and then typically the sensors so will be placed on the central area. I mean, for left, right, right here. So about the main brain responses that we have in the state of the art, so to create non-invasive brain-computer interfaces. I use ERP a lot, also for rapid serial visual presentation tasks. Steady state. I mean, if you interested, I mean, come in my lab, put the cap on you, and then you can, and then you can spell anything. Can spell your name. So by using a keyboard based on steady state visual evoked potentials. So all those things, it's really for people with severe disabilities. I mean, for motor imagery, you can imagine someone who cannot use hands for typing, for using a keyboard. For ERPs, well, you look at typically visual stimuli, but if you can move your neck, I mean, your eyes, you can control your eyes. I mean, there are different bottlenecks that can happen. I mean, controlling your neck, you can look. I mean, if you use an eye tracker, that's going to be difficult because you still need to control your eyes. So there are some people cannot really control their eyes, and using an eye tracker can be a challenge. So using a brain-computer interface can be a solution. So it really depends on the disability. So there are different different brain responses for different type of disabilities. Here we have the main loop. I mean, it's a closed loop system, and that's very important. It involves different fields. I mean, signal processing, after machine learning, AI, so for feature extraction, classification of the brain responses. Then you recognize the command, look at what happened on the screen, if it worked, if it doesn't work. You may also get used to the task. So your brain responses are going to change, and that's a big issue. So I have a slide, I will mention it later on, but the EEG has some non-stationary properties, and for lots of responses, I mean, you train a system, you have an AI system, I mean, you have your model. Your model is not going to work all the time. I mean, you have to track the different changes, and that's a big issue. So yeah, this loop, so it involves different fields. So yeah, signal processing, AI, so computer science. I mean, there's people can work on the sensors. You need some knowledge about cognitive neuroscience to know what type of brain responses you need to extract, detect, and then what are the effects. So once you have some feedback. So it's for who? Well, healthy people, it's possible. So that can complement, augment other outputs that you may have. I mean, you can use the mouse, the keyboard, and at the same time, you can think about different things, and then these responses can be used. Personal enhancement, prosthetic limbs. I mean, if you can use your hands, you can use your feet. Maybe you can imagine having a third arm or an additional leg or to do other things. So there are lots of possibilities. Exoskeletons, smart home systems. So if you just look at something and then you could activate the switch, that's something that could be interesting. Healthcare, so communication. So that's mainly for severely disabled people. So for instance, locked-in patients, you cannot use an eye tracker, you cannot use I mean, just completely locked in. In this case, thinking about moving left, moving right. So that's the main, probably the only possibility for these people to communicate. Rehabilitation, post-stroke rehabilitation. So let's say, I mean, if you want to reinforce some connections, so you have an issue, you cannot move your hand, you cannot move your arm, and then so when you try, so you can measure the responses in the brain about I want to move my left hand, my left arm, and then get the feedback about how your brain is activated in relation to what you want to do, and you can have this loop, and you try to reinforce what's going on for your rehabilitation. So that's one possibility. Neurofeedback, I mean, that's related to the rehabilitation. Now, which is not really about interfaces, so health monitoring, stress management, so those things, you detect brain responses, not particular more waves, not precise responses. I mean, there are different ways how you can do it, but it's more to let's say you focused. Are you focused on a particular task? For instance, for decision making, are you able to do a task the right way? So that could be used for this purpose. So health monitoring purposes. stress levels, different mental states. So there are different ways how it can be used. I've used, yeah, I mean, data sets, so corresponding to, it was for sedation. So if you want to monitor, so how much you have to it was for propofol, so how much you have to put, like if you want to determine the brain states after sedation, after sedation, then try to recover. So you want to put the right amount of drug. I mean, you want to put someone to sleep, and you can look at brain networks before, after, and then you can compare with behavioral measurements. Like, I mean, at some point you can ask people, can you do this? Can you do that? And then you can put more drug, and then you out. I mean, you know, really if the person is sedated. And then, so by analyzing the brain networks, I mean, brain responses, so you can tell if someone's conscious or not. So there are ways how you can use signal processing, machine learning, and all those things. So to extract features from the brain responses, so to determine the level of consciousness. So when you create an interface, there are different ways how you can do it: synchronous, asynchronous. So are you going to have an application where you have to follow a particular page to enter the command, or it can be anytime. So that can be more complicated if it's asynchronous. For detection of brain responses, so you have different types, as I mentioned: response versus no response. That could be one step, and once you have a response, you want to determine the category of the response. For the inputs, you can work in different spaces: time, space, frequency, space. Space can be in 1D, can be in 2D. You can look in the sensor space. From the sensor space, you can do the source space, so way in the brain, so you have the activities, and then use what happened in the brain, I mean, based on the sensor space, in order to determine the different classes you're dealing with. So there are some challenges over there. Now, main approaches are deep learning, Riemannian geometry. I mean, I'll just keep these things. So if you're interested, come to science too. Come in my office. So the main problem is it has to leave the lab. It has been there for decades. Brain-computer interface. I mean, you have lots of labs all over the world. So there are some. It's multidisciplinary. So you will see. I mean, for instance, in Berlin. So this group, their background is in machine learning. You're going to find some in Austria, signal processing. I mean, signal processing, computational neuroscience. Same in Germany. You have different groups. So you cannot find really a group. It's just brain-computer interface. We have from machine learning or signal processing or psychology. So it requires lots of people. So does it work? Can it work? So yes, now the problem is far along. I mean, you have a system, it was tested in the lab, you got your different participants, you do statistical analysis, you get 50 people, you run, it works fine. But I mean, if it has to go out for real patients, for people who are going to use it all the time, now you have to make sure that it's going to work all the time, right? So that's an issue for testing. So you have across how many people, over time, I mean, the duration of the sessions. So there are lots of things you have to think about in terms of the variability of the signals, variability of the users, and then you have to adapt. So that's, I mean, what's one solution, or in the worst case, to be able to tell, well, now it doesn't work. And you can tell, okay, well, call the clinician, call someone, call the nurse to say, well, now you have maybe to recalibrate the system, but at least you have to do something. So to detect when it doesn't work, then there's a chain of distribution of the responses, the feature you're dealing with. So that's very important. When you have a shift, that's important. So main issues, so for the EEG, so for the analysis and also for other physiological signals, so is the non-stationarity. It changes over time. So if you have a system, train, use AI, machine learning, then things are going to change. I mean, it changes across participants, across subjects, yes, but for one individual, it's going to change for lots of reasons. For what you have, for the quality of the responsive, the signals, what you get from the sensors, so electrical impedance, So you have state-dependent dynamics happening in the brain, time varying connectivity. So lots of changes occurring over time. And if you say it works, you outside the lab. I mean, everything can go out of the window. Plus, lots of the experiments, so they are done in very well controlled environment. Now, if you bring the noise so from the computers, from other devices, when you measure the brain responses, then so for instance, I've been trying with some students so to combine so VR and the EEG. So when you have the VR headset right here and the sensor over there, I mean the noise that you get from the VR headset on the sensor, in particular for the frontal area, I mean forget about everything that you can measure with these sensors. So typically, so you can find systems where they include altogether VR and EEG, but the EEG is always just there. So parietal, occipital, and that's it. So another very important thing that is needed in BCI and in AI in general, so explainability. So you have a patient, they need to know why it works, why it doesn't work, why for me it doesn't work, why at some point the system is not going to work anymore. So you need to explain. You cannot just say, okay, well, try it. Maybe at some point it's not going to work. I don't know why. I mean, it's machine learning, it's AI, whatever. So you need to tell why it's going to stop, why it's going to, why. So the explanations are very important. So even for clinicians, there's a system. I mean, what type of brain response is going to be extracted? So what's going to happen when you wear the EEG headset? So it's trust, acceptance for the patients, but also for nurses, clinicians, everybody. I mean, everybody has to trust the system. And if it's just AI, okay, well, it has been trained on this data set. You trust the data set. I mean, change of people. I mean, you tried with people with particular type of disability, and now you expect that it's going to work the same way people with different types of disability, or you know, it's a big challenge. Well, safety, I mean, it has been mentioned in other presentations. So explainability is very important. I don't know what the time. Oula. Okay, so yeah, so understand why not, knows why, when it fails, when it succeeds, when to trust the decisions of your AI system. So that's important to get some measurements. I mean, that been mentioned earlier, but it's a communication between the AI system and the human beings that are around. And at the end, we can make the final decision about can use the system right now, do we need to recalibrate, and it's a conversation with the AI agents about what can be done at any moment. So conclusion. So there are lots of issues. So to leave the lab. So non-invasive techniques. I mean, you cannot change the laws of physics. You cannot. I mean, also problems with air. I mean, if you cannot force people to shave their head, you cannot force people to open their skull for invasive BCI. So you have challenges in AI, machine learning with non-stationarity, in physiological signals, explainability of all the weights, everything that's trained in the the AI systems. And quite often, I mean, the BCIs are not just used alone. So you have hybrid BCI, so it's AI, BCI with eye tracking, BCI with VR, BCI with regular controls, BCI with, in my lab, I have some switch that I can use with the mouth. So you can look, select. I mean, you have to combine everything. It's not just one technology, and it takes a long time to leave the lab. So it's not. Yeah, I mean, it requires multiple technologies from different disciplines, and it's all about collaborations and trust. Very important to trust with stakeholders, trust with users, and to make sure that we can reach potential users, because if they don't know that the technology exists, then there's no demand. No. And yeah, that's it. I have some links. I mean, you can find me online. Sorry for the voice.
we would like to kind of give these gift baskets to our panelists and our speaker. So I'll call names and please come forward. And first is to our keynote speaker, Todd Norwood. Let's take a picture together. You are facing. Yes, yes. Molly, you have to come forward. Ooh. Are you okay? Thank you. That's right. She's doing good. These are beautiful. Todd, stay here. I'm going to take later. You can just stand there. Yeah. Yes. Okay, our next speaker I want to call is Dr. Seema Pulispati. Let's take a picture with Seema. Oh. Something is happening. Thank you. Thank you. Seema, stand with Chad. None other than Dr. Hanako. Yes, yes. Oh, she's a favorite. Yeah. Molly. Okay. I would like to call Dr. Hubert. These are heavy. They told you. Okay. Yes, yes, yes. Let's. Yes. Come with us and have a picture with us. Yeah. Yeah. Thank you, Hubert. And Sylvia. Johilo. Now I know how I pronounce your name. Thank you for coming to so far. Oh, thank you. Yes, let's have a picture together. Come, come, come. I want to get the background. So online panelists, just wait for us. We are just getting things in order with felicitation, and then we'll be back. Thank you. Thank you. Thank you. Good job. Okay. Okay, so far, yeah, please have a seat. Okay, for our online panelists. We have online panelists. So our next panelist is Dr. Stephanie Walkman. So introducing Dr. Walkman, just give me a second. So Dr. Stephanie Wakeman, serves as the clinical director at OneStep, a leading digital healthcare platform leveraging motion intelligence for clinical grade motion and gait analysis. With a background in microbiology and physical therapy, including a clinical doctorate, Stephanie's expertise spans orthopedics, digital health, and health promotions. Committed to merging technology with compassionate care, she drives innovation in healthcare delivery and population health, championing the practical application of health technology for societal well being. The topic of her talk is revolutionizing rehabilitation in the digital era. Please welcome Stephanie.
Hello, everyone. Thank you so much, Nupur. I am really grateful to be here. Thank you very much for this opportunity. Nupur, are you able to allow me to do screen sharing?
Yes, just give me, you can share your screen.
It says the host disabled participant screen sharing.
Okay, yeah, just give me a second.
Hi, everybody. Looks like everyone's having a good time over there.
Yeah, see now if you can, you are a co-host now.
Ah, perfect. Thank you. All right. Is everybody able to see my screen?
Yes.
All right, great. Thank you so much. Thank you, everyone in the audience. I really appreciate taking time out of your evening to be with us today. As Dr. Nupur Hajala just said, my topic is revolutionizing rehab in the digital era. And I'm going to be speaking to the practical knowledge and application of remote therapeutic monitoring, or RTM. So our learning objectives for this quick presentation are going to be to explain why the adoption of technology is important to the profession. And I logged on a little earlier today and listened to the great panelist discussion. And it sounds like there was a lot of good discussion around why it's important to the profession. And we're going to explore some ways you can leverage RTM as practical technology to enhance the patient experience, and understand how to vet RTM options to choose the best fit for your environment. And I heard a little talk about that in the panel discussion too, not specific to RTM, but for technology in general. So I'm glad to hear this is all kind of coming around full circle. So we want to ask ourselves, what are the main problems we're trying to solve with technology? And two big problems that come to mind, one we're very familiar with, is addressing declining reimbursements. So this is a topic that has had a lot of discussion for many years. And I just want to review that over the last 3 years, there's been considerable cuts. I'm not going to spend a lot of time on those cuts, but we'll just look at what happened in 2021, where there was a proposed 9% cut and it was reduced to 3.3%. In 2022 and 2023, there was a combined cut of 4.5%. And then this year, as you probably are all aware, there was a proposed 3.4% cut, and there was a measure that was passed to reduce that to 1.7. So all in all, for the last 3 years, there's been a total of 11.2% reduction in our reimbursement. And this is really concerning for us as a profession and for our livelihood, and concerning for how well we'll be able to service our communities. And so we need to find ways in which to bridge the gaps of that reimbursement reduction created, so we can continue to do the great work that we do and continue to serve our communities. And so the other problem we're trying to solve is to improve patient outcomes. And so one way to do that is to facilitate easier communication between the therapist and the patient. And technology has many different ways to improve the ease of that communication. Can also help encourage active participation in the plan of care for the patient. As we all know, patient outcomes improve when they're actively engaged in their care plans, and technology can be a method in which to help them engage a little bit more. And therefore, they'll have improved functional independence and safety. So the digital revolution is here to help you with all of these things and help you to grow existing and new revenue. It can help you capture the value of the interventions with objective data. I heard a discussion in the panel earlier about how important it is that we capture objective data to demonstrate what we're doing is creating improved outcomes, right? There was lots of talk about big data earlier. And so technology can help us gather this data to learn from it and to show the value of what we do. Technology can also help streamline patient-provider communication and to strengthen rapport and strengthen that therapeutic alliance. It can also help to drive the patient engagement and satisfaction. And as was also discussed earlier, it can help increase access to care and reach patients who maybe otherwise couldn't come into the clinic and help retain more of those patients. And it can also help elevate the profession. You know, we need to move forward with technology. It's here. We need to adapt it and we need to learn how to use it. And digital care is ubiquitous in the modern healthcare paradigm right now, and we need to jump on that train. And I think that's what the summit here, what the summit is all about here today is how to jump on that train and move forward with it in a safe and equitable and effective way. So let's define what RTM is. So remote therapeutic monitoring is a service in which you're remotely monitoring your patients when they're not in therapy time. So it is a way to know what your patient is doing when you can't see them. And so we now have a way not only to do that, but to also bill for that. And RTM is a set of codes that will allow us to monitor for this musculoskeletal data, non-physiologic musculoskeletal data, such as mobility, gait patterns, exercise adherence, response to the exercises, patient-reported outcomes, and it also includes respiratory care. It includes 5 CPT codes to bill for all of that monitoring and data collection time. 4 of those codes will relate to the musculoskeletal, and 1 of the codes is specific to respiratory care. And it is also a requirement that the data must be collected with an FDA-listed or approved device or software. So that relates back to that element of safety that was discussed earlier. So what are these codes? They're really complex, actually, and very nuanced, and we really don't have the time today to dig into it too much, but I just want to give you an overview of what these codes are. So the first code, 98975, that is something that you can bill for the setup of the digital device or the software program to set that up for the patient and to educate the patient. And that's a clinician responsibility. So you have to deliver that device, teach the patient how to use it, and then you get reimbursed for that. The second code, ending in 77, that is your data collection code. And really that's incumbent upon the patient to collect that data for you. And it enhances, therefore, their participation within their plan of care a little bit. So they have to either collect data through mobility, through computer vision, through monitoring, some type of mobility through different, various forms of technology, answering questionnaires online, things like that, and providing their response to exercise interventions. Those are all data points, and this code will allow you to bill for collecting 16 days of data in a 30-day cycle. So that cycle can start and stop at any time within a month. It can start in the middle of the month and then end in the middle of the next month. So that's a 30-day cycle. And then the following 2 codes, 80 and 81, those are time management codes. Those codes are the time that can be reimbursed for when you are looking at and monitoring and analyzing all of the data that was collected. So the first code is code 80 would require 20 minutes of monitoring time for a single patient and 1 interactive communication. So that can be an in-person visit outside of other billed therapy times. It could be a telehealth visit, a telephone call, any medium that works for the patient. And it can only be a few minutes in which you're taking a moment to discuss with the patient what their data looks like, how it's impacting their outcomes and their plan of care. And that also allows you to effectively intervene in their plan of care very early instead of waiting for next week when the patient comes back to tell you that specific exercise bothered them and therefore they didn't do their plan of care. Now you have a way to monitor it. They can send you feedback, and then you can give them real-time changes to their home exercise program without wasting any time and enhancing their outcomes. So this is just a way to facilitate the care that you're already providing with RTM in your practice. The example I just gave of helping change the plan of care for a patient who is struggling in real time. That is a way to facilitate the care. And it's important to know your why, your who, and your how. So knowing your why is understanding what is your intention for implementing RTM in your care pathway. Is that intention to improve patient outcomes? Is it to increase your revenue? Is it to improve patient retention? Is it to provide an alternate work option to retain talent? We would all love the flexibility to work from home on an occasion when a child is sick, maybe when we're not well, maybe the weather is inclement and no one can get to the clinic. We now have options to provide a continuity of care and to provide flexibility for ourselves and our patients. Explaining what this is all about to everybody that is going to be involved. So the clinicians, frontline clinicians, it's important that you all understand, clinicians understand that the RTM can really help strengthen that therapeutic alliance with your patients. It can really improve the value of the therapy that you're giving. And that additional data will give you information of more clinical insight and can help with clinical decision-making that you may not have had before. And it also creates opportunities for early intervention and upstream care. And you have to explain this why to the patient. It's going to take some extra time and extra effort for the patient to do this as well. So it's important for them to understand what's in it for them. Why is this important? Well, because it's going to save you time, Mrs. Smith, by recording your data and your mobility at home. You're not going to have to come into the clinic 3 times a week. We can do it just 1 time a week, and the rest of the time we can do it through remote monitoring. That's going to save time. That's going to be convenient for the patient. And also it's going to help them reach their goals a little bit faster. So know your who is going to be the best RTM vendor. So that's a difficult question, and it's going to be very specific to every individual situation. But questions you need to ask yourself is, what problem am I trying to solve when I implement this specific technology? What is the goal for using RTM? We listed some goals a few slides back. Is it to improve patient outcomes? Is it to improve ROI? And we're therapists, right? We need to set SMART goals for ourselves, just like we set them for our patients. So we have a way to measure a success by these very specific metrics. So defining that success through setting some SMART goals for yourselves. And then important questions for your vendor. It's important to understand what foundational technology is needed to be successful with RTM. There was a discussion about this earlier too. What is the broadband requirement? What type of Wi-Fi am I going to need in my building? Am I going to need specific tablets or iPads? All very important questions to ask and understand. And what kind of support is a vendor going to offer? The vendor should offer education on the service and the product. They should train the staff. They should offer various types of training and certainly offer around-the-clock tech support. And then knowing how long it's going to take to see that ROI. It's important because, as I mentioned, we need to sustain ourselves and our livelihood to continue to serve our communities. And when we invest in something, we definitely want to see a return on that investment. But it's important to understand that with RTM and really any technology, it takes a long time to see ROI. If you invest in it today, it's probably going to take 3, 4, maybe even 5 months to really see the full potential of that technology. And then asking what patient populations are going to be most successful with this technology. So who is involved with implementing RTM or any other technology? And the answer really is everyone. Everyone within the clinic space, the front desk staff, the support staff, all clinicians, PTAs, PTs, CODAs, OTs, it really involves everyone, and everyone needs to have an understanding before the service is implemented. and just understanding how to facilitate this remote monitoring, understanding that this really is an extension of what you're already doing, right? You're providing patient care, and now you're extending that care beyond the clinic walls and offering a more streamlined service for your patient. So you're enhancing your care delivery and just providing that seamless, continuous care. And it's also important that you start small. So if you're looking at implementing it in one building, starting with 10% of the staff instead of 100%, or if you own many buildings, starting in one building before you expand to all of them. And then it's important to identify your project leaders and clinician champions. It's important that there's one person who is really excited about using technology and can be the cheerleader for everybody else on the team to encourage them to use it and to help them when they struggle with it. So RTM impact so far has been pretty good. It's improved patient engagement about 6 times. It's improved the billing has been 96% successful. Functional outcomes on PSFS scores have increased 58% according to what we have seen, and the utilization of the RTM data to support things like justification for ongoing care have been successful at about an 82% rate. So thank you so very much for listening, and that's all I have. Thank you.
Thank you, Stephanie. Thank you for your time. So our next speaker is Dr. Alan Lee. He is from the Department of Physical Therapy in the Mount St. Mary University, LA, and is a leading figure in the field of telehealth. Dr. Lee has devoted his career in advancing innovative practices in physical therapy, and as the Director of Technology SIG in the Academy of Leadership and Innovation, he spearheads efforts to integrate telehealth into clinical practice. Dr. Lee's leadership roles, including co-chairing the Telehealth Clinical Practice Guidelines, work group and membership in the First Council of American Physical Therapy Association, underscore his influential contributions to shaping telehealth standards and practices. His research focuses on optimizing telehealth for physical therapy, demonstrating his commitment to enhancing healthcare delivery through technology. Dr. Lee's expertise and dedication makes him a trailblazer in telehealth, driving advancements that benefit both practitioners and patients. The title of his talk is The Lessons Learned in Telehealth. What keeps you awake at night?
Thank you, Nupar. Can you hear me okay?
Yes.
Excellent. Okay, let's get started. I really learned a lot from the panelists so far, and today I hope to kind of encourage you to think about what Dr. and President Sandoval said about health equity, what Ms. Trujillo had mentioned about value of patient advocacy, what Dr. Wakeman, as well as Dr. Cicchetti talked about noise, or maybe finding the right and the best RTM situations that would influence telehealth, as well as what hopefully will help you not just stay awake, but sleeping well at night. So this is a data set on the right. If you look at this slide deck from Optum, and what they did was they collected data prior to the COVID pandemic in the blue dots on all health specialty areas in a large data set from endocrinology all the way down to chiropractors, including physical therapists and other disciplines. And prior to COVID, in blue, you notice that physical therapists' utilization of telehealth or telemedicine applications was about nearly at 0 to 3%. And what you notice during COVID, and when they compared that data, about a year in, is that they found that physical therapy utilization of telehealth as well as telemedicine was about at 5% in this orange or round dot. To me, that sends a message to all of us to think about what is missing or what keeps you awake at night. Well, not all patients require telehealth, but yet on a hands-on field like us, we were not, again, trained to utilize digital health in our training 20, 30, 40 years ago. But yet, with COVID, we had to launch into practicing digitally, but also with telehealth, synchronous and asynchronous modalities. So the future advocacy, as Ms. Triello mentioned, is, what is the true value, not only for our profession, but for our patients? One of the ways to think about this is really in the future, perhaps from 5%, we can push forward to about 30% of our patient panels or our patients that we see in pediatrics to all the way to geriatrics that could utilize some amount of digital health as a complement to an in-person or a hybrid approach of telehealth applications or practice in physical therapy and other rehab applications. So in order to do that, I think it all needs to be based on evidence. So most recently, we were able to publish this telerehabilitation in physical therapist clinical practice guideline from American Physical Therapy Association. This is an international guideline that includes Argentina practitioners, Canadian, Australian, and the UK physiotherapy practitioners, including the US physical therapists. In this guideline, there were 7 recommendations that led to evidence quality of low to moderate to high evidence, as well as strength from weak to strong evidence in terms of recommendations. Let's just take one of these recommendations, which is on your right side. Physical therapists should anticipate, prevent, manage, and document occurrences of adverse events specific to telerehab as a mode of delivery. Although in the literature prior to the pandemic and during the pandemic, there were really low levels of adverse events, I believe as a physical therapist and a healthcare provider, for patient safety, you need to anticipate and also prevent and mitigate potential adverse events. Let me give you an example. A patient with a history of seizures should understand that the practitioners cannot provide hands-on emergent response if there's a seizure event that occurs during a physical therapy session via telehealth. Hence, we need to educate, anticipate, and prevent, but also manage if such an event occurs by understanding the emergency protocols at the patient site versus the practitioner site to deliver that type of delivery of service. Although the literature was low in terms of quality of this recommendation, we believe APTA Code of Ethics strongly encouraged physical therapists to think about such recommendations and prevention and mitigation of adverse events. So that's what keeps me awake at night as we push into digital health. AMA also thinks about not only digital health, but to Dr. Norwood's point, such as he mentioned about Steve Jobs' iPhone, which has what I call the diffusion of innovation, the key rule of Everett Rogers' implementation of technology and diffusion of innovation, where you think about interface between that iPhone with music or text messaging and a telephone. Now we need to think about telehealth or digital health interfacing with AI. To the point of Dr. Sandoval, as he mentioned, the bias or potential health inequities that could also be presented by just an AI system. So the American Medical Association really sees the practitioner at the center and not the machine, meaning it's augmented intelligence or augmented care versus artificial intelligence. We as rehab professionals need to think about some of these risks, such as bias, end user understanding of these models, as mentioned by Dr. Cicchetti earlier about the noise, about hallucinations or deep fakes, even in digital health, liability, coding, and payment, as mentioned by Mr. Jello, and Dr. Norwood's point about privacy and security needs to be managed with AI as well. And the regulatory landscape is really advancing and changing quickly, so practitioners need to understand and stand firm about what is it? Is it augmented or is it really artificial? There are some opportunities for us though. So to sleep well at night, Optum Labs have worked with artificial intelligence in collecting big data and really using AI and leveraging it to extract the best insights and data. To me, data informatics in physical therapy is the key, where you aggregate the data for our populations of rural as well as metropolitan areas and harnessing that AI opportunity to really like minimize bias, be transparent, and also safely safeguard patient information and their data. So in conclusion, I do want to provide you with the short video from a patient. This is a patient of Sarah Gallagher, who's a neuroclinical specialist with a patient who've had vestibular issues for 2 years. She provides in-person as well as hybrid approach of telehealth. And this is what the patient said about the ability to see Sarah via telehealth through a video conferencing system prior to the pandemic. I hope you could hear the video.
I've been having vertigo for over 20 years, and most of my adult life, I've been almost 80% housebound. I've been just gradually getting discernibly better and better, and I'm off medication that I was on 20 years. I'm able to go out now and go to restaurants and go shopping on my own and drive and just live again. The whole thing has just worked, and I just can't say enough about it.
Dr. Lee, we cannot hear the video.
Oh,
Can you summarize for us?
I apologize about that. I did click share video as well as audio. However, the patient was just reminiscing about how she had history of vertigo for 20 years and mentioned how the telehealth sessions with Sarah has ability for her to not only do those exercises at home, but also being supervised by her caregiver, her husband, who could videotape the sessions, as well as she was able to get off her medication, and everything has worked. I apologize about the audio. It's such a tech glitch, just like our telehealth session could be. So people need to know what that is. But in conclusion, the telehealth tools are part of clinical practice, but the clinicians and patients are in control. So I'd like to thank you, Nupar, and also panelists for this encouraging summit at your institution. Here are some of our international physiotherapists and physical therapists who led the charge on telerehabilitation CPG. But again, I'd like to thank you for this opportunity.
Thank you. Dr. Lee. Barbara Ruby.
Hello, good evening.
Dr. Rubino is a board-certified internal medicine physician, currently serves as an Associate Chief Medical Officer at Covered California, with a relentless focus on primary care access and equitable outcomes. Dr. Rubino's expertise and unique perspective enriches her efforts to improve healthcare quality and access for patients across Covered California. Dr. Rubino?
Hello, good evening. Hopefully everyone. I'm sorry, I thought I heard a comment. Hopefully everyone can see and hear me. My name is Barbara Rubino. Thank you for the introduction. I will go ahead and share my screen. Great, can you confirm that my slides are visible before I jump in? I think it's sharing the wrong screen.
I see them. Oh.
If I go full screen, are you still able to see everything?
Yeah, we can see the slide.
Great. Thank you so much. Sorry for the delay there. My name is Barbara Rubino. Good evening. Thank you for having me. I think I may be towards the end of your session, so really appreciate you sticking with me. I'm the Associate Chief Medical Officer of Covered California, which is the California State Health Benefits Exchange that oversees the administration of insurance through the Affordable Care Act to over 1.8 million individuals across the state. I'm going to jump into a topic around virtual care and really talk about the opportunities and challenges in ensuring high quality and equitable delivery of care through a lot of what's proliferating currently across the virtual care spectrum and various point virtual care solutions that are out there that are highly reimbursed. A little bit about me. I am an internal medicine physician. I trained at the LA County Department of Health Services at LA General Medical Center. I am a primary care doctor and have a very traditional sort of outlook on quality and care delivery and what true high quality equitable care looks like. And several years ago, kind of took a leap and went to work for a health tech company, Oscar. Oscar Health is a health insurance company that serves people across the nation through delivering insurance through the state health benefits exchanges and is built on a full stack technology platform. So me, a very traditional primary care doctor from the county system, went and worked at a health tech company where many folks felt that it would be great to shake up healthcare, but the ones developing some of these technologies had often not ever set foot inside a hospital or a clinic. And I learned so much from this experience and really grew in my own expertise and as a leader in how to use technology to deliver high quality care, and had quite a bit of a reckoning with bringing these two things together. The perspective of sort of the public health system and health tech companies. And really that's what led me to work for Covered California and think about how to bring these different parts of the healthcare system together to better serve patients at the state level and to influence health policy. Today, we're going to talk about a few topics, and my perspective is really both that of a primary care doctor, a healthcare leader, and somebody who's delivered care virtually and developed systems to deliver care virtually that serve patients across the country. We're going to distinguish between virtual care point solutions and the telehealth modalities used by traditional healthcare teams. We will look at the current landscape of virtual care solutions, and then we will talk about the evidence and what impact these point solutions are having on quality and equity. So here's where we will sort of start with what's in scope and out of scope for today. So we've heard a lot about virtual modalities that are available to be used by traditional healthcare teams and that may augment both the in-person component and our ability to deliver care to patients in a place and in a way that they want to receive it. This type of virtual modality used by traditional healthcare teams have a lot of evidence to support their efficacy, to support the patient experience. But what I'm going to talk about today is really virtual care point solutions that are out there, that are proliferating, that are disconnected from the traditional healthcare space, and that have a less of an evidence base and a sort of smaller body of research around patient safety and outcomes and what they actually deliver, aside from quick access to care and the ability to sort of use any modality that a patient is interested in. there's a lot going on in the economy and across the nation that has contributed to the proliferation of these virtual care solutions. There's just a tremendous volume of virtual and telehealth companies that have popped onto the scene, especially accelerated by COVID. There's a tremendous amount of money that's being invested and projected to be invested in these companies. There are a lot of big employers and big tech who aren't really in the business of healthcare and who are now entering the scene and developing their own virtual care solutions. And there are retail clinics all over the country that are often leveraging virtual services or stacking virtual services on top of their retail clinical services. So with all of that, there's been this sort of proliferation of virtual care solutions. And this is a typology that was published a couple of years ago that shows this sort of range of both types of patients served, segments of patients served, and payment models being used to pay for the care being delivered through these innovative primary care models or virtual forward models. The other thing that's not represented on this slide is really that there is so much instability in this space. And some of these companies that were in this article when it was published about a little less than 2 years ago are no longer offering care, and that can be very disruptive. You'll see here that there's quite a few of these models that use risk-based contracts or say that they're going to deliver value-based care and require payment from an insurance company only if and when they hit an outcome or save money on ER admissions, for example. And insurers put a lot of eggs in these baskets and contract with these companies with the hopes that that will happen. And that doesn't always pan out. And we'll talk a little bit about why that is in a couple slides. And then, as I mentioned, all of these modalities, all of these types of solutions are covered by insurance. And across Medi-Cal and commercial health insurers in the state of California, video, audio, store and forward communication, app and text messaging are all covered. Behavioral health is covered. There's no in-person visits required. So these are very accessible modalities. And these companies that I was just showing really know that they're gonna be able to get paid. Medicare represents about 12% of the coverage market in the state of California and actually does have more restriction on what's covered. Notably, it will require in-person care at specific intervals, depending on if medical care or behavioral health care is being delivered via video. But overall, the vast majority of folks in California can receive virtual care through their traditional healthcare teams, through these point solutions, and it's fully reimbursed. So we'll jump a little bit to what the impact of all of this virtual care that may or may not be connected with the rest of the healthcare system is having. So some good stuff. Retail and virtual care clinics can effectively treat many acute conditions. There's evidence that certain conditions like urinary tract infections or uncomplicated acute infections can be treated at a lower cost without adverse safety outcomes in these sort of point solution or in a retail setting. We also know that these modalities really deliver timely access to care, and patients are usually highly satisfied with them, and that they serve patients that actually otherwise don't engage with the traditional healthcare setting. The flip side of this is virtual care services are inequitably distributed and utilized. That's across race and ethnicity groups, that's across income groups, that's across primary language, depending on the primary language that the patient speaks. And they may increase healthcare costs if they're used in a way that's disconnected with the rest of the healthcare system or with healthcare providers who know the patient. So a virtual visit with a non-familiar PCP actually increases the 7-day ER visit rate, the likelihood that somebody is going to visit the ER within the next week after they were seen, compared to a virtual visit with a team member that the patient may know. And then I'm just sort of mentioning retail clinics here again, because I sort of mentioned them in the previous slide. They often have virtual offerings associated with them. There was this thinking that retail clinics and all the services that they offer, including their virtual care services, could decrease ER rates for people because they would seek care there in a more efficient, convenient way. Than it is to go to an emergency room. And in fact, this was studied and there's no impact on ER rates for people who live close to, have access to, and have coverage to go to these retail clinics. And then I mentioned this, and I'll just say it again, there's a lot of instability in the tech-enabled models, and this can disrupt relationships. And relationships and continuity are actually key to bending the cost curve of healthcare spending. And this is a study that was published last year that showed that increasing regular and highly continuous primary care to a point had significant overall total healthcare expenditure savings, and discontinuous primary care or discontinuous care delivered across a variety of settings or with folks who are unfamiliar with the patient had a negative impact on total healthcare spending, and really a deleterious effect on healthcare costs, ER rates, and far more that has been studied. So what does that mean sort of for us and our positions, and what can we do going forward? What we know today is virtual care is widely available, but inequitably deployed and inequitably utilized. These virtual care products, when they're not connected with the larger healthcare landscape or people or providers or teams who know the patient, may have deleterious effects on overall cost and quality of care. And virtual care, despite all of that, will continue to be reimbursed across California for the great majority of enrollees, except those 12% of folks who have Medicare, who have a little bit more stipulation around in-person care being required. So we can and we should demand ongoing rigor in the research that's done that measures the impact and the efficacy of virtual care quality. We should be looking at telehealth policies with an equity lens and thinking about how we support patients and people who are traditionally left out of care delivered in these models. And we should heavily engage with insurance companies and policymakers to share our feedback and to advocate for the changes that we know need to be made to address these. And that is it. Thank you.
Thank you, Dr. Rubino. Speakers, thank you, everyone. I really enjoyed listening to you, and thank you, everyone. Have a good night.